more evidence that PhD is Latin for a doctor who can't help you, and how much we actually really do need the health system going well. So what I want to do is just sort of wrap up, and then we'll crack it open for Q&A. The big takeaway for me is that the way we fund healthcare is creating this link between what happens in the healthcare system and jobs. And so the title of this paper is Who Pays for Rising Healthcare Prices? And the answer is really, really straightforward. It's workers. Right? Which workers? It's workers earning between $30,000 and $100,000 a year. Right? How are they paying for it? They're paying for it with their jobs and a small portion with their lives. And that in many ways, the way we want to think about rising healthcare prices in the US is like a tax, right? It's a hospital tax. And this tax is affecting jobs. So what do we want to do? Like, how do we, if we want to lean into this, what are our options? The first is, I think, that state-level engagement is critical, right? So this is getting state AGs involved, talking to them about why this is so important, right? It's things like what Oregon is doing, which is a board that's going to review hospital mergers as they go through. The second, and I think it's uncomfortable to say out loud, a lot of the markets are already consolidated, right? So we have this challenging question of how you unscramble eggs, which is really tough to do. One way to do it is getting patients to travel farther for care, right? Many of us shop over long distances for lots of things that matter less than healthcare. Can we get folks comfortable and make it easier for them to potentially travel farther? That makes markets more competitive. And the last one is, what do we do in the markets that are already truly broken? And I think for better or for worse, it's probably time for us to consider price regulation in those markets, right? It's something that most economists worry a lot about, but also something that most of us are coming around to. Which is something I really never was going to expect. So with that, we'll just kick it open for Q&A, and as much time as y'all want.
We'll do just a couple minutes of Q&A. We've got staff members with microphones. I've got someone right in the front with their hand up.
Thank you. I'm Michael Myers, New York Civil Rights Coalition. My question is, I just need some current information about access to hospitals. In the old days, at least, you had to, if you were poor, you had to go to the poor hospitals. And if you had income or extra help, you went to the private hospitals. Now, how have Medicaid policies and Medicare policies changed access to private hospitals, number one? And number two, with respect to paying the hospital bill, how does that affect the hospitals who have charity for patients? You may not be able to pay your insurance policy may not be able to pay the whole total bill, but we have charities. We have millionaires who will help you pay your hospital bill at the end. So that's my question to you.
Yeah, let's take the second one first. It is amazing that we have to have hospitals offer charity care in the first place. I think it speaks to the need to guarantee that everybody has health insurance coverage. So one of the things that, I think one of the big policy successes over the last 2 decades has really been expanding access to health insurance. Right? It's been pretty remarkable. Rate of uninsured gone down by 50%. That gave many more people, right, tens of millions of people, insurance. I think what we've seen over the last couple of years is that rising costs are now an access issue, right? We got insurance, right, uninsurance. Now, in a sense, what we have is under-insurance. And so I think going forward, the way I talk about health spending is really as an access issue, right? Because if touching the health system, even with insurance, bankrupts you, people don't want to. And I think maybe the stat that we can sort of close with on that question from Michael is about 44% of folks with full insurance coverage in the US report delaying care because of fears about costs, right? That's the sort of next step for us, is getting that number down.
Thank you. Other questions? I'm going to go. Yes, sir. Oh, Spencer, you got it?
Yes. Okay. Thanks. The question is, where do you see innovative virtual care fit into increasing competition, reducing travel for farther care, things of that nature? PCP as well as specialty.
Yeah, so I think it's two areas. So the first is rural care. Like I think one of the big roadblocks to a lot of pro-competition policy, or basically anything that lowers, sort of puts more financial incentives behind hospitals, is the question of what it will do for rural hospitals. So I think we have to sort of carve them off, and rural care can help with, or telehealth can help with a lot of those challenges there. I think in terms of competition, it's basically making a hub and spoke model for highly acute care easier, right? So that I can get my high-end cardiothoracic surgery probably somewhere a little farther than where I have in the past, and have sort of continuity of care with my physicians over time, potentially digitally. So I think it's basically making that travel lower friction and then allowing that to expand markets.
We're going to take one more question. You've had your hand up, and then we'll call it quits.
Thank you. Thank you for your presentation this morning. Andy King is the name. Just have a quick question in regards to, you mentioned that when these mergers take place, that the everyday worker from 20,000 somewhere up to 100,000, they take the brunt of struggling through that merger. Is there a way, or is there a plan in the future maybe to put together some type of formula that when mergers like this take place, that those who make those mergers who don't get affected, that they can take the brunt of it, as opposed to the everyday New Yorker or American who has to struggle, take care of families with such these type of mergers?
It's a great question. I mean, in some ways, I'd rather see the mergers not happen in the first place. You know, so I think what we need to do is sort of say, how do we identify these mergers in advance? Turns out we can. And then how do we take the steps to stop them from leading to the price increases we talk about? I think, you know, then you get into the question of if they happen, how do we make it fairer? And I totally take your point. Need to think about it.
So let's give a big round of applause to Zach Cooper. Who spoke under some trying circumstances. So we're going to jump into the next phase of the program. I do want to recognize a few additional guests who've come into the audience. We have the 32BJ SEIU New Jersey State Director Anna Maria Hill here. Welcome. Thank you. We love seeing New Jersey so well represented, which we're going to continue with in a moment. We also have retired New York Assemblyman Dick Gottfried here, who knows a lot about healthcare, and we're happy to have him here. Thank you. So I'm very excited for this next gentleman to speak. Ross Baraka is the long-standing mayor of Newark. And he is really a testament to the role that public purchasers play in driving market reform. We sometimes think elected officials only deal with policy and private purchasers only deal with markets, but in fact, there's a lot of bridge between them. And in 2023, the city of Newark made the very courageous decision to leave the state health benefits plan. And with its 8,000 lives, ventured out on its own, but it said things were just too expensive. They engaged in direct contracting, they worked in their community, and in that first year, they saved over $10 million. So think about if every purchaser chose to be that engaged and look at their data and do the work, what that would mean. So we're gonna spend the next hour and a half or so really looking at ways to potentially do that. So I am so pleased to have you representing both the state of New Jersey and the efforts of this community. So Ross Baraka, Mayor of Newark.
Thank you. I guess we'd get better health care if we were Olympic athletes and we went to France. We get a taste of what free medicine healthcare looks like. But first, I just want to thank 32BJ, the Service Employees International Union, for inviting me here today, and more importantly, organizing us to be here to talk around this very important issue of healthcare. Also like to thank you for your relentless advocacy and tireless work to protect the rights of working people in our state and across this country. It inspires all of us who fight for equity and justice in America. More importantly, and I know there are a lot of people here, a lot of industry folks, a lot of advocates here as well, but I just want to take a moment to support organized labor. We know that organized labor has been a clear and direct route to the middle class, has pulled generations of Americans out of poverty. And let's be clear, we're not just talking about something that benefits union members alone. When organized labor is at its best, it lifts up every worker in our society. It's not just about wages or hours for those in a union. It's about better health care, higher wages, expanded paid sick leave and family leave, and greater job security for all workers. A stronger, more vibrant labor movement is a tide that lifts all boats, a movement that demands equity, fairness, and justice in our workplace and our communities, that makes America live up to its values and ideals. And for decades, the unions in this country have not just been fighting for their own members, they've been fighting against a powerful, deeply entrenched corporate agenda in DC, in state houses, and in boardrooms across the country that seek to take care of a few while the majority of workers in this country bear the heavy burdens of the rising cost of uneven taxes, growing wealth and power concentrated in the hands of a shrinking minority in this country. There's a corporate agenda that succeeds. It is not just union members who lose, we all lose. All of us who believe in a fair society, a just economy, and a democracy that represents every single one of us, because unions are our nation's backstop. They are supposed to be the floor we as working people of this nation stand on, and we know very clearly that this nation and its families are strong only when unions are strong. So that being said, I want to thank every one of you for being here today fighting the good fight. And we are here today because in this country, and specifically in my state, New Jersey, there are two very serious driving forces behind the rising and unbearable cost of living, and that's housing and healthcare. Healthcare has become clearly out of control, the cost, and cannot be regulated by the market anymore. In 2020, while the country was in the middle of a pandemic, insurance companies doubled their profits. As public health systems struggled to find resources to contact trace or administer tests, CVS Health that year reported $3 billion in profit just in the second quarter alone, which was $1 billion more than they made at the same time the previous year. United Health had $6.7 billion in profit at the same time, which was $3 billion more than they made the previous year, all in the second quarter in the middle of a pandemic. And while this was happening, hospital costs had also increased and were continuously increasing, from hospital stays to regular procedures. In fact, even before COVID, hospital costs or overcharging, like in New Jersey, cost the state over $1 billion. All of this put on the backs of working class families in this country. In New Jersey, while state and local governments are insuring less and less people, the costs are still skyrocketing, driven by rising cost of insurance. And at the fundamental part of that is the unregulated, uneven overpricing at hospitals, where the costs are privately negotiated between hospitals and insurance companies. This happens without any real oversight. So as public sector employees fight for better contracts, many of those gains are fed right into an overbloated and unregulated healthcare system, where taxpayers and working families are bearing the heaviest brunt. Healthcare is personal. It's personal to me, and I know it's personal to everybody in this room. But here's the truth. Healthcare is not a luxury. It's not a privilege. Healthcare is a basic human right. It's not like choosing between two different brands of sneakers or the best place to go on vacation. It's not a consumer choice to be made in the marketplace. It is a fundamental necessity, one that requires collective resources to meet the basic human needs of every person in this country. Everyone, every single person in this country should have access to affordable health care now. And yet, here in the richest country in the history of the world, we have a political and corporate class that has somehow not been able to agree on this basic fact that healthcare is a human right, that all of us need healthcare. We're still fighting about whether the market should take care of us as opposed to whether we should take care of each other. The vast majority of Americans agree that people should have access to health care and should not fear bankruptcy when they get sick. Somehow, greed and profit have corrupted a system that never should have been in the hands of profiteers in the first place. This is not just a moral failure, it's a failure of our democracy, a failure of our values, and it's a failure that is costing lives every single day. In Newark, our experience exemplifies everything that is wrong with our healthcare system. Newark is the largest city in the state. We have thousands of public employees. We have an aging population that relies heavily on hospitals as their primary care providers. And we are a city that theoretically should benefit from being included in a larger insurance pool like the statewide state health benefits plan to maintain costs and spread the insurance risk around many folks. But in 2023, the city of Newark was staring down a double-digit rate hike for our city's employees, not because our employees were using their benefits more, but because prices in this system, especially in hospitals, are out of control. I sat down and looked at what these rate hikes would do to our employees' paychecks, and I knew we had to do better. Newark, our employees, and our taxpayers could simply not afford it, and eventually we made the difficult decision to leave the state health benefits plan. It was difficult because we know in a system like this, we are supposed to be stronger together. We know that pulling out of the plan would in turn hurt other public employees that remained in that plan. But in the first contract alone, we saved the city of Newark more than $10 million. Now, how is that possible? How is it that a couple of thousand employees are cheaper to insure per person than 800,000? That goes against everything we were told about how the marketplace works. Our negotiation power should have been weaker, not stronger. But the moment we introduced just the smallest amount of competition, we saw massive savings for both taxpayers and employees. It doesn't add up. And that tells me something fundamentally is wrong. We're not playing on a level playing field. The system must be rigged, and it is rigged against ordinary people. The hospital conglomerates raise the prices, the insurance companies that take more of the pie, and the rates are passed on to the backs of workers. It tells me we need more regulation, more oversight, more transparency, more accountability to bring this broken system into the light of day. Healthcare is just too important to leave to the whims of an anti-competitive, consolidated market and the greed of the few over the needs of the many. So what do we do about it? First, we bring transparency into pricing, especially hospital pricing. Prices vary by patient, by insurance provider, by hospital, by doctor, by referral. And the hospitals, they're the only ones in these negotiations who have all the information. The result, hospital prices are rising faster than any other part of the healthcare industry. They are the #1 driver of rising healthcare costs in the state of New Jersey. But they are only getting away with it because they operate in the shadow. We don't have to accept this. We can be like, as was said, Oregon or Massachusetts. We can demand transparency. We can set cost growth benchmarks or price caps. We can pass new legislation in the State House that will fortify the Office of Healthcare Affordability and Transparency. We can hold these powerful institutions accountable at the local level if we stop supporting people who are more focused on contributions from hospitals than the fact that the bills from these hospitals are bankrupting the people that vote for them. Listen, we don't have to punish the hospital. That's not what I'm saying. I think they're essential for the health and safety of our communities. But we also cannot allow them to operate unchecked while they extract more and more money from families already struggling to make their basic needs. And let's be clear, hospitals are just one part of the problem. We must also take on the insurance companies, this industry. And we must completely overhaul our relationship as elected officials with the pharmaceutical industry. We need to stop treating these industries like untouchable giants. Instead, we must start treating them like what they are, businesses that exist to serve the public good, not to exploit it. So in New Jersey, we have Chapter 78, which means more employees have to pay a greater amount of their income or salary on their health care costs. And as these costs balloon out of control, workers pay more. They see less take home in their salary. And suppose you were a worker for Department of Public Works or a building service worker. Your salary is already smaller than that of a police officer or a fireman or a lawyer or an executive. And Chapter 78 means you pay more money, more for hospital costs. You have insurance because they told you that if you get insurance, that the insurance will pay the hospital costs for you, and that these emergencies wouldn't bankrupt you or hurt you or drive you into the poorhouse. But the opposite is happening. The insurance packages that we're giving them is actually doing the same thing if they didn't have insurance at all. Together, though, the good part is that we can make these changes. We can build a healthcare system that works for everyone, not just the wealthy and the powerful. But to make this a reality, it's going to take all of us in this room, organized labor across the region, our elected officials, industry professionals, and advocates, especially at the state levels and municipal levels to prioritize this fight. While the wealthy have lobbyists, working people elect people to stand in their stead to represent them, to fight for them. While the wealthy have people representing them, everybody else relies on the governor. This is not a challenge we can afford to ignore. This is about healthcare. It's about lives and livelihoods that are at stake every single day. We simply have no other choice but to win. We have no other choice but to win. And what we figured out lately is that when we fight, we win. Thank you.
Okay, that should get us all worked up for the rest of the day. I wish I could say that we'd given him those talking points, but that was amazing. Truly. So we have a couple, we're going to introduce a couple of our New York legislators, but I do want to acknowledge Assemblywoman Tapia from the Bronx who came in, who isn't up at the podium, but I wanted to acknowledge it's so fantastic when we see elected officials here because as they learn and get absorbed in this issue, it's that kind of action that it's going to take for us to make some of the changes that Ross Baraka just talked about and that we're going to spend the rest of the morning discussing. So it is my pleasure to introduce New York City Councilwomen Lynn Shulman and Julie Menon. This is a powerhouse duo of women, which is always a great opportunity to introduce. Councilwoman Shulman, is the chair of the Committee on Health, and she has been an indispensable ally in efforts to provide access to high-quality, affordable health care for all of the residents of New York City, and we count us fortunate to have her as an ally in our efforts to support the Office of Healthcare Accountability. I'll also be introducing Councilwoman Julie Menon. Yeah, come on up. Julie opened our very first conference with an announcement of her plan to introduce legislation to create an Office of Healthcare Accountability. That feels like yesterday and years ago at the same time. She was a fierce supporter of it, and it passed unanimously, which doesn't happen very often, and is continuing that fierce advocacy to make sure that the promise of the office is realized. So thank you to the two of you. We couldn't have come this far without you, and I'm going to turn it over to Lynn and then to Julie. And you can stand at the podium or use this.
I'm going to go to the podium, but I'm short, so I'm going to hold this. Height challenged, I should say. So I'm Lynn Shulman, and I am the council member for District 29, which includes Forest Hills, Kew Gardens, Richmond Hill, and a small piece of Rego Park. I'm also the chair of the Health Committee. I had a speech today. I'm going to try to truncate it a little bit because I know there's a lot going on. You've heard from a lot of people. So one of the things I want to point out, I'm going to give you a number, 4,750. I know people don't know what that is, but I'll tell you what that is. That was the cost of my colonoscopy recently when I went somewhere that was affiliated with Mount Sinai, when Columbia Presbyterian charges $13,000 for the same colonoscopy. I got wonderful medical care, And that shouldn't happen. That shouldn't happen. As the chair of the Health Committee, my primary responsibility and goal is to ensure that New Yorkers have access to affordable, high-quality health care. And you've heard this before, I'll say it again, health care is a human right. And we have to make sure that we keep working until that actually happens. And it can't happen if you can't afford it. The cost of health care in the city is spiraling out of control. Over the past 2 decades, health insurance costs for our city's workforce and retirees have skyrocketed from $1.6 billion, you hear this, $1.6 billion to a staggering $11 billion. And what's driving this? The exorbitant hospital prices charged by the 5 largest health systems in New York City. It sounds like the 5 families, right? And I want to tell you something, as chair of the Health Committee, I'm not that popular with these systems because I fight for everyday people. So they don't like that so much, and they've made that known to me. And I tell them that they may need me as chair of the Health Committee, so they need to listen to me. So some of them actually do, I have to say, but not all of them. So as I mentioned before, colonoscopy can cost $13,000 at New York Presbyterian. I told you what mine cost. At Lenox Hill, it could be $3,400. Look at these prices. They're all over the place. There's no real standardization of any kind. And I think mostly a lot of these systems, we're paying for the real estate. We're not paying for the cost of the health care. So several elected officials and myself, including myself, recently sent a formal letter to New York Presbyterian Hospital regarding their anti-competitive behavior, which we believe has contributed to the inflation of these outrageous prices. But despite our efforts to engage them, their response has been far from meaningful, demonstrating a lack of accountability. Their practices continue to raise serious concerns about how they are hindering competition and access to affordable health care. This is where the city's new Office of Healthcare Accountability comes into play. I am proud to have worked alongside my colleague, Councilmember Julie Menon, who spearheaded unanimous passage of the Healthcare Accountability and Consumer Protection Act. Please give her a round of applause. But we could not have done that. I was a co-prime on that. We could not have done that without your strong advocacy and fighting. We was at so many rallies together, and we went to so many forums, and we pushed and we pushed and we pushed. It was a lift. It was a lift because there was fight back on it. The legislation established the Office of Healthcare Accountability, and it's going to be a game changer in our fight for transparency and fairness in hospital pricing. The office will be a vital tool in our efforts to bring clarity to the opaque world of hospital pricing. We must shift the paradigm so that transparency becomes the norm, not the exception. As we move forward, I'm committed to working closely with Councilmember Menon and the rest of the City Council to ensure the robust implementation of this office. And by the way, the legislation was passed last year, and it took a big effort on Councilmember Menon's part to get the mayor's office to actually open the Office of Accountability. So again, we really appreciate her efforts. And together we will confront the hospital affordability crisis and ensure every New Yorker has access to the care they need without facing financial ruin. Now I have the pleasure of handing the mic over to Councilmember Menon, who will continue this vital conversation. Thank you so much.
Thank you so much. I really want to give a round of applause to my amazing colleague, Councilmember Lynn Schulman, who has been a fantastic chair of our health committee. So I am Julie Menon. I am the council member that represents the east side of Manhattan. I first of all want to thank 32BJ and its incredible president, President Manny Pastrich, who has been such a champion for lowering skyrocketing healthcare prices. This is a third 32BJ healthcare conference, so I was here last year telling you that we had just passed this bill to create the Office of Healthcare Accountability. and I'll tell you a little bit about some of our efforts around that. So in passage of that bill, we worked tirelessly with 32BJ, DC 37, and an incredible labor coalition, along with Councilmember Lynn Shulman, Councilmember Mercedes Narcisse, and others, to make that legislation a reality. Ever since I came into office, and my background is as a regulatory attorney, and I formerly served as the commissioner of the Department of Consumer Affairs for the city, I've prioritized reducing skyrocketing healthcare costs. Medical debt, we all know, is one of the leading causes of debt for New Yorkers. In my legislation, the Healthcare Accountability and Consumer Protection Act that was signed into law directly addresses this pressing issue. New York City has a population larger than 3/4 of the states around the country, but this is the first time we know of this kind of effort happening at the municipal level. As the first of its kind in the country, the Office of Healthcare Accountability is going to empower New Yorkers with the critical information that they need about hospital pricing to help all of us make more informed decisions. And I say this again as someone who's practiced consumer protection law for almost 20 years. If you think about it, there's no other area where you're procuring a service, and yet, albeit at your most vulnerable time when you're in the hospital, you have absolutely no idea what you're going to be charged. And you come home from the hospital and you're socked with this massive bill. By bringing transparency to this oftentimes opaque area of healthcare, we aim to better manage and reduce costs for both the city and for all New Yorkers. So this pioneering effort not only benefits New Yorkers from the consumer protection angle, which I mentioned, but it really positions New York City at the forefront of innovative urban policy. I'm so pleased that we are now taking this very, very important step. Now, in terms of the other reason why this bill matters so much, there's also the fiscal reasons why it's important. A study by 32BJ showed that this legislation can save the city $2 billion. How? Because we're going to harness the city's purchasing power to drive down prices. Now, interestingly, New York City, with our over 300,000 public sector employees, is the second largest purchaser of healthcare in New York. The 32BJ Health Fund is the fourth largest. So the future of our city and state truly depends on us lowering these skyrocketing hospital costs. So I want to talk a little bit about this. If you're a woman and you're giving birth by C-section in New York City and you go to Montefiore Hospital, you will receive a bill for $55,000 for that C-section. That same C-section is $17,000 at another New York City hospital. Councilmember Shulman gave a great example of a colonoscopy, and look, we all need colonoscopies sometime in our lifetime, so she gave a really good example of that. As the council member who represents Hospital Alley on the east side of Manhattan, this is an issue of grave importance. New York Presbyterian Hospital and others are charging up to 300% of Medicare rates, 300%. So, and Councilmember Shulman referred to this. So in the year 2000, the city spent $1.6 billion on health insurance for our public sector employees. That covers the employees, it covers them when they're retired, it covers their dependents as well. That number in 5 years ballooned up to $6 billion and is now $11 billion today. That, by the way, is 10% of the New York City budget, I just want to mention. So this is obviously costing the city billions of dollars a year, and that is why we were able to put together an unbelievable coalition to enact this groundbreaking legislation. Now, a couple other things that I just want to mention. It's not enough to just pass a bill. I think oftentimes legislators get excited, you pass your bill, it's the end of it. That is not the end. That is half the battle. The other half the battle is to make sure that it is implemented. So 32BJ and myself worked really, really hard to convince the mayoral administration to actually fund this office. And I do want to remind everyone, this is during a climate of massive budget cuts cuts that the mayor was enacting. So this was not an easy battle. But I'm so happy to say that we won that battle. We got the office fully funded. It will have 15 employees. It is housed within the Department of Health, and we got assurances, and the Department of Health is now working on this. They are actively meeting with other stakeholders, including, and I'll just mention a few, Indiana's Employers Forum, New Hampshire's Insurance Department, Brown University, Turquoise Health, the Loan Institute, Arnold Ventures, Bentley University, and more. And I mention that because we know other states have done an effective job on price transparency, and we want to be able to utilize those best practices and utilize that data to lower our costs here. So in closing, we are thrilled to be able to announce today that the Office of Healthcare Accountability is open, it's fully funded, it is doing the critical work, and you can rest assured, because the City Council, we have oversight power, and my colleague, Councilmember Shulman, I don't know if she's still here, but is chair of the Health Committee. That is a committee, and the Hospitals Committee, chaired by Councilmember Narcisse, they have oversight here. So we plan on utilizing that. So in closing, I just want to say how excited I am and how optimistic I am that we are going to be able to tackle this issue head on in New York City. Now is clearly the time to address head on these inflationary, bloated, skyrocketing hospital prices. And the last thing I will just say is it's important to note that New York City hospitals get approximately $1.5 billion from the city of New York in tax breaks. That's right, $1.5 billion. So this is a time where we need to hold the hospital's feet to the fire to finally lower these prices. Thank you so much.
Okay, you heard the two councilwomen. We have some work to do. So we're about to jump into our panel that talks about some of the policy options to build on the excellent work that the New York City Council has done. And I drew the lucky straw because I've gotten to introduce a lot of very powerful women today, and I've got two more coming up to the roster. We have State Senator Liz Krueger and Assemblywoman Chantal Jackson. These two very powerful legislators will be sharing information about legislation that they are about to introduce, the Fair Pricing Act. Senator Krueger is the chair of the Senate Finance Committee. She was with us last year at the conference and talked about the importance of getting data and using data. And this is a woman who is walking the talk because that's what we're about to do, and we'll see some dramatic impacts, I think, in the state of New York if her legislation is successful. Assemblywoman Jackson, who is her House co-sponsor, what she brings is a unique perspective. She's been such a tireless champion for health and wellness for her constituents in her community, and that perspective of firsthand seeing the impact of prices on the people in her district is a constant important reminder for all of us that this work we do impacts real people. So I can't imagine a better powerhouse duo than the two of you to tackle the Fair Pricing Act.
So I am Assemblymember Chantal Jackson. I represent the South Bronx, South Bronx. I'm very excited to be here and have this conversation about the Fair Pricing Act, which is our bill that I share with Senator Krueger. I also happen to be the chair of microbusiness at the State Assembly. And so this bill is going to impact not just the individual, but the employer, the small business employer, the unions, everyday New Yorkers, teachers, you name it, it is going to impact them. So I'm not a healthcare worker, but I am a social worker. And one thing I know is people, and I know habits. If the price of coffee, we're gonna talk about coffee for a minute. If the price of coffee that you go to your local coffee shop is $1, and then the next day, this big company that we will call Starbucks buys your local coffee shop, and that same coffee that you would get for $1 is now $9, They didn't add any razzle-dazzle to it. They didn't put any extra creamer in it. It is the same exact coffee that you got for $1 a day before is now $9. And it's only because Starbucks bought it. That's what we're seeing within our healthcare system. I am now 40. God willing, I'll be 41 next month. And now it's time for myself and everyone my age to get a mammogram. The mammogram that I get on the regular basis, on a yearly basis rather, from my local doctor down the block from me on Concourse Plaza, is charging one price. And the second this big name, Bontefiore, goes on top of my now local doctor's office, now skyrockets that price of mammograms. It is no longer the standard price I was paying the year before. That's what we're talking about. We're talking about flu shots and ultrasounds and mammograms. Things that we are asking New Yorkers to get regularly are now, the price of those things are increasing. That is the problem. That's what we're looking to solve. And we want to make sure that there's transparency in pricing, right? We want to make sure there's transparency in pricing. We want to make sure that there's a cap, that you don't get to decide today that the colonoscopy is $5,000, but tomorrow when Bontefiore buys it, it's $13,000. We want to make sure that there's a cap. We want to make sure that there's transparency. We want to make sure that there's accountability and enforcement. The Fair Pricing Act is going to be addressing all of those things. So as a legislature and representing the South Bronx, there are some things that my constituents deal with that maybe you all may not deal with. But we're known for a lot of things. We're known for high rates of obesity, diabetes, heart disease, asthma, you name it, we're facing it. And there are two things that could happen within my district. One, the person is either not going to the doctor and I have to encourage them to go regularly. That's one thing that's happening. Then the other thing is that they're spending way too much time in the doctor's office because of their constant issues of health, around health. And so the last thing I would love to see happen, or like to see happen, is that my constituents decide, well, the yearly mammogram costs more now, so I'm not going to go. The flu shot costs more now, so I may not go get it. The ultrasound that I needed costs more, so I may not go and do that. Physical therapy, I'm going to cut back on because I can't afford it. I would hate to see that happen from a district that's already facing all of these issues. So that's why this is extremely important to me and extremely important to my district. And so I'm going to leave it at there. I'm excited to work with Senator Krueger on this. I am the baby in the Assembly. I've only been there for 4 years, so I'm looking forward to the leadership and the impact that I know Senator Krueger brings with every single bill that she has introduced and passed. Thank you.
Good afternoon, morning. Morning. Hi, I'm Liz Krueger. I'm the senator representing the East Side and Midtown and Chelsea and Roosevelt Island. I've got a great district. And I'm delighted to be working with Chantel on this. She describes herself as a baby in the Assembly. I will tell you that my mentor on anything in health policy, who served 52 years in the Assembly, is sitting right behind her, Dick Gottfried. So I'm so glad that he's here. And afterwards, he'll tell us what we need to fix in the bill, so that's even better, sincerely. And I'm delighted to be here with 32BJ. And delighted to be here with my colleagues, Julie Menon and Lynn Schulman, who might have had to leave already, on coordinated work we're all trying to do at the city-state level. People have talked about this bill that we haven't yet introduced as being potentially controversial. So I just want to go on record. I represent Bedpan Alley, all the major hospitals in Manhattan. I'm delighted to have them in existence and in my district, but they're wrong on a bunch of things. And health insurance companies are here, and I've already been told that somehow this is good for insurance but bad for hospitals. I don't really like insurance companies, nothing personal, but I just have big problems with insurance companies, so I don't think I'm doing this bill for you. And unions obviously have articulated why this is so important for them, for their membership. Sometimes I agree with labor, sometimes I don't. I'm delighted to be working with 32BJ on these health cost issues because they have shown amazing leadership. And as one of them described themselves, they're sort of policy nerds here on health funding. And I love policy nerds, okay? I get my best information from smart people who've done their homework, who can pull out the data and say, look at what's happening. So I was thrilled to be here and hear the professor from Yale and the Department of Justice expert talking about exactly what I've been seeing and thinking I understand, but they expanded my understanding so much more, and I think yours also. And I am not a baby in the legislature. I've actually now been there 24 years. So I can remember 24 years ago, everyone was talking about, oh, we have problems in healthcare. Maybe we need to allow all these hospitals to merge. That will solve the problems. Didn't solve the problems. Maybe we should have reduction in the number of insurance companies and there'll be economies of scale in the costs. Yeah, that didn't work either. And of course, what we aren't necessarily talking about yet today is the fact that as we had conglomerations, we also had a bunch of hospitals close, not necessarily in the areas we needed hospitals to close, and it was actually reducing access to health care, particularly in lower income communities, not just in New York City, but in upstate New York also. We're all city folks here, I think, but these issues are national, as we've heard, but they're also statewide, which is why the state needs to confront these issues, right? Now, a unique, perhaps, experience from being in Manhattan, the hospitals now control all health care. I have advocates who come to me to tell me all the time, and they're right, we need to be putting more money into preventive care, primary care. Our goal was to not have everybody get sick and end up in hospitals. And I'm like, yes, that's right. That's the target goal. And yet, as we're hearing today, and I am seeing every day in my community, there aren't really doctors or healthcare providers to go to that aren't hospital affiliated because they bought them all in, or they basically said, we won't work with you unless you're part of us, so you won't be able to get admitting privileges if you need a surgical room, so you might as well just become part of us. And so they sort of been taking over everybody. And then I heard, but it'll be okay because we'll do all this outpatient programming and that'll be cheaper. Except it's not. In fact, what we're seeing is the costs continue to skyrocket. And then we were told, no, it'll all be good because there'll be improved facilities, better access. But they went into all these joint ventures with private investment firms. And so now you have a profit motive built in to all of this access to health care that in theory is getting better and better, but if you talk to people, isn't getting better and better. And it's certainly costing a lot more. And yes, I'm also government. So when we're talking about the numbers that, for example, 32BJ did an excellent presentation, or their report on the cost to labor unions having to negotiate for better salaries for their workers and then try to explain to their workers, but it's all going into your health insurance costs, sorry. We're seeing that the state of New York is a huge funder of health insurance for a huge number of New Yorkers, not just in our cost in the Medicaid program, but a lot of those state workers in unions are actually our workers, so we're paying for their health insurance, or through their unions for their health insurance, and that's ending up also costing us more as the state of New York. So I'm not a health committee person, but I am the finance chair, and so every year I have to deal with the fact that the state of New York doesn't have enough money for all the things we need to be taken care of. And I always explain, being the state finance chair for the Senate isn't really a good gig. because 9 out of 10 people are mad at you all the time. Because you have to say no 9 out of 10 times. So people think, wow, what a great gig. If you're interested in having this job and you're in the Senate, let me know, because it's exhausting and you're really depressed all the time because you're always saying no to everyone you agree with. But which is why when something like this idea comes along, where you can actually make a difference through transparency and some realistic, as was described, price caps. I've gone too long. She's telling me to get off. I understand. You can save money for consumers, save money for government, and help us move towards a fairer, more equitable healthcare system. It's not a magic bullet. There is no magic bullet. But it is another step we need to take. And just as I leave, it's not radical. We actually had price caps for hospital services in the 80s and 90s. So this is not, oh my God, what are they talking about doing? This is an actually relatively small step to get us to bigger goals. And thank you very much.
So what Senator Krueger is saying is that this is actually a vintage proposal. So thank you so much, Senator Krueger and Assemblywoman Jackson. So we are going to convene our first panel. That was a great segue into the panel, which is going to really focus on policy efforts to lower hospital prices. So Misha Sharp, the Health Fund's Assistant Director and my indispensable partner, is going to bring the panel up, and we will jump right in. And if we could have the mobile mics brought up, so thank you.
Yeah, please take a seat. You came from DC. I came from
Fantastic. Good morning. My name is Misha Sharp. I'm the Assistant Director for Policy at 32BJ's Health Fund. We have a really exciting panel for you all this morning. I'll quickly introduce them, but I also want to say how thrilled I am that Senator Krueger and Assemblymember Jackson could be here to introduce the Fair Pricing Act. It is an enormous step for New York, and though not a wholly new concept, one that we believe will make a massive impact for everyday folks and workers. So quickly introducing our panel, and then I'll give us a quick orientation before we hop back to our panel for some questions. We have a star-studded panel with us this morning, national experts who will really talk to us about fair prices and better markets and policies to help create those things. We have Lindsay Vagoda, who is from Colorado, but has recently started a New York chapter for the small business majority. We have Erin Fusay-Brown, who's faculty with Brown University's Center for Advancing Health Policy Through Research and has a deep background in working with all sorts of ERISA and healthcare cost laws, drafting all sorts of model legislation with NASHB. And then we have Sophia Tripoli, who's the Senior Director of Health Policy with Families USA and who is an incredible advocate on these issues at the federal and state level. So quickly, I'll turn over to the slides. If we could get the next slide up, please. We're going to be talking today about largely site-neutral payment. You can see from this fantastic chart from the Center for Georgetown Health Insurance Reform, right up there at the top, that site-neutral payment and specifically price caps through those policies have immense promise in 3 ways: for lowering patient out-of-pocket cost, for lowering overall healthcare system costs, and for increasing transparency and oversight. You can go to the next slide, please. So what is site-neutral payment when we talk about it? Because we're going to talk about it a lot today. So put simply, site-neutral payment is paying the same or close to the same price for a service regardless of the healthcare setting. A lot of these policies focus on basic routine services that you heard Assemblymember Jackson and Senator Krueger talking about, things like flu shots, mammograms, and x-rays. And we're often talking about these services when provided either in the hospital outpatient setting or the doctor's office. We're not talking about inpatient, and we're not talking about emergency services. These are also not new policy concepts. So Medicare really started this movement with the Bipartisan Budget Act of 2015, and we'll hear more from Sophia and others on the bills that are on the table and their likelihood for passage in the rest of this session and in years to come. Next slide, please. I have a couple of pieces of data that are 32BJ Health Fund specific, and we have much more detail on these in a paper that my team has worked really hard to put together to establish the evidence base for site-neutral payment. You can pick up print copies of that on the right side of the room over here. But you can see here the price differences in basic imaging services, whether they're in the doctor's office or in the hospital outpatient setting. So you're seeing here 2 times, 3 times the price increase for basic imaging services that really don't vary too much based on where you get them. Next slide, please. We've also seen a large shift of these services moving to the hospital outpatient department. So I often say these services may or may not be moving. It may be that what was formerly a doctor's office is now being coded as a hospital outpatient department. And so bada boom, bada bang, your price goes up by 2 or 3 times. So we talked about that a lot of these patterns and shifts have occurred because of consolidation, and you heard Zach Cooper talk about that a lot. But I wanted to draw your attention to some of the consolidation that's occurred in the New York City market purely from an assets and revenue perspective. And I want you to pay attention to this $24 billion on the bottom of the screen. These are 4 health systems in New York City. They have $24 billion in net assets. They are making $37 billion in their total operating revenue, which I'll say is over half of all patient care revenue in the state. If that's not consolidation, I don't know what is. We've also seen a couple of really relevant mergers coming to the table now with not a lot of oversight. So you've got the Northwell-Nuvance merger that's going on right now. Last week, the state's committee approved it. 0 conversation about pricing, 0 conversation about its impact on healthcare affordability. So with that context, I'm going to take a seat with our panelists and turn it over to you all. Zach talked a lot about consolidation this morning, and so I wanted to get some of your perspectives about what this really looks like on the ground and how people experience it. But Erin, I really want to talk to you first about how consolidation contributes to a lot of these price differences that we see by setting.
Yeah, so thanks so much to 32BJ for hosting this important conversation. I'm really thrilled to be here with such terrific colleagues and such great speakers. I think the biggest thing to understand is that no matter what we hear, consolidation is the largest driver of price increases and of price variation. So it's not the sickness of the patient population. It is not utilization, how much volume or services are being used. It's not the aging population. It's not the demographics. It is the market power. And what we heard all this morning, I think, from both the Department of Justice and from Zach, is that we have evidence to show that this is, in fact, entirely a market power driven phenomenon. And as a result, we'll never get a handle on healthcare affordability, which is driven by rising prices. Unaffordability is driven by rising prices without tackling the market power that comes from consolidation. And yes, that also contributes to the price variation insofar as all of the variation you see in those prices, again, it comes down to the market power of the entity, not, again, the sickness of the patient population, the quality of the services. So when we pay more, we're not paying for more or better care, we're just paying for their market power.
Thanks, Erin. Is this on? Everyone can hear me? Good. Sophia, I want to turn to you first because you all have done a lot of story collection from patients and families about how they actually experience a consolidated healthcare system and how they experience some of these billing schemes more broadly. So would love if you can tell us more about that.
Absolutely. Just want to say good afternoon, or still maybe good morning, and thank you very much to 32BJ for hosting this meeting, and all of the work you guys are doing to make the fight at the state level. I think the biggest issues for consolidation for consumers are really, number one is affordability. We heard a lot already about the way that Rising prices driven from healthcare consolidation, particularly hospital consolidation, is driving up in premiums and out-of-pocket spending and all the different forms of cost sharing that you experience. And the trade-off of what happens when your premiums go up is that employers have to absorb more and more of the total cost of healthcare, and it's at a huge expense. It's about at the expense of increasing wages. And so we've seen stagnant wages, pretty significant over the last several decades. That's less take-home pay for working people across this country because of the impact of hospital consolidation on high and rising healthcare prices. And I would say the third impact is really about access. A lot of times what we're seeing happening in these mergers and acquisitions is big hospital systems, these massive corporate entities coming in, they're buying up local physician practices. In some cases, particularly in the case of private equity mergers and acquisitions, we're seeing hospitals close the doors, they're cutting service lines, reducing access to needed care, forcing the people in that community who rely on that hospital and those services to travel miles, sometimes hundreds of miles, or they have no access at all. And for many of these communities, this access is literally between life and death, particularly when we're in the midst of a maternal health crisis. And those are often some of the lines that we see cut most often when we see mergers and acquisitions. And so there are a number of stories, and particularly around site neutral payments and the lack thereof in our healthcare system. In the ways that people come in, they're paying the same, copay. All of a sudden, that hospital system buys up your physician practice. You don't think anything of it. Instead of getting your care on the first floor, you're going to the fifth floor. Same doctor, same service, but now instead of paying $30, you're paying $1,500, a 4,000% increase. And why? It is because of the incentives in the system that are encouraging big hospital systems to shift patients to higher cost care, buy up local practices just so they can get a higher reimbursement rate from payers. And so it's a significant problem that we're seeing across the system.
Thank you, Sophia. And last, I want to turn to you, Lindsay. I want you to tell us more about who the small business majority constituency is in New York, and really what the business case is for small business owners caring about healthcare consolidation and the impact that it has on healthcare prices.
Thank you, and I also want to echo thank you so much for putting this together. It is such an honor to be on a panel with amazing women and doing the work alongside you all. So Small Business Majority is a representative of New York's 2.2 million small business owners across the state that employs more than 4 million New Yorkers. Small businesses make up 99% of the businesses in this state. And healthcare is an issue for them. Small Business Majority, we focus on a lot of issues, but particularly want to focus on the smallest of small businesses, as well as those facing systemic inequities. And we hear time and time again that healthcare is one of the top issues small business owners are facing across the state. And again, healthcare is inherently a small business issue. It's the single most sought after benefit that a business could provide to recruit and retain a workforce. The lack of healthcare access might be a deterrent for someone starting their business if their healthcare is tied to their job. And health-related costs can torpedo a small business at nearly every stage of a micro enterprise. We've seen that time and time again, because oftentimes if you're running a small business and it's just you're employing yourself and maybe one other person, your personal and business expenses are so interrelated. Though we often tell people don't do that, it's the fate and the reality of it. And the first problem is that small businesses don't have access to HR departments. They are the Renaissance people of our time. They are the handyman, the manager, the scheduler, the boss, the funder, the recruiter of their small business. They have to do everything. They don't often have the capacity to figure out where to find healthcare, how to get affordable prices, and to negotiate. And that's also a huge problem. Small business owners don't have a lot of negotiating power. They're not like these big corporations who can negotiate with an insurance carrier or find the right providers in their network to lower costs. They don't have that type of power. And so what we see is, due in large part of consolidation, these prices that are not equal. Larger firms are paying less for healthcare than our smaller firms, which is chokeholding our small businesses. And it's increasing time and time again. The costs, and you'll see some slides in a bit, the costs are overtaking small businesses, and small business owners are paying attention. They know it's because of hospital consolidation. So it's a huge concern. And if we don't tackle that, it will have far-reaching problems, inflation, unemployment, and other concerns that will affect our economy completely.
Great. So we've talked about how site-neutral payments can both lower the prices that we pay for care, but also how they can impede some of these healthcare consolidation incentives that currently exist in the market. However, I think no one will be surprised when I say these policies so far have faced immense challenges in terms of getting passed at the federal level, and presumably at the local level as well. And so I know you each have been deeply involved with generating robust evidence around these policies. And so from each of you, I'd like to hear about what information or evidence that you and your organizations have used to establish the need for site-neutral payments and other policies at the state and federal level, and which of these findings really seems to resonate the most, both with the public or with legislators and policymakers. Sophia, we can start with you and then just move down the table.
Sure. I think the thing that resonates the most with policymakers is consumer stories, and we all have one. You know, everybody. I'm just curious, actually, how many people in the room have had an experience with the healthcare system where they can't afford their bill, or they get a surprise bill of some kind, or the cost of their premiums, they're questioning whether they can afford them, or you have a family member, a close friend. Curious, raise your hands. How many people? How many people? Guys, that's basically the whole room. So we got to get your stories out there. They got to hear the policymakers. They have to understand what the real world impact of rising prices is on your lives. And everybody has a story to tell. And I think that is the most compelling information that policymakers are hungry for. They want to understand what the impact is. And then I would be remiss if I didn't say, like, all the amazing work of researchers and academics like Aaron and Zach, and tons of others around the country who are crunching the data, pulling out the numbers and helping us understand the impact in the markets, and what is really happening. Because the truth is, the hospital, the business model, they do not want us to know. That's why prices are hidden. That's why we don't know what the price of healthcare is until you get a bill in the mail, because it's proprietary information. It's buried in contract terms. And so anything we can do to unveil pricing, tell your stories, enact site-neutral, same service, same price types of policies is going to help us chip away and tell the story for policymakers.
Yeah, so speaking of the data, one of the ways that we know that vertical consolidation, the one that we're talking about today, where the hospitals are buying up the physician practices and all of it's now being billed as a part of the hospital, even though they're just your physician's office, is that there are payment incentives baked into the way Medicare pays for these services, and then that's copied in the commercial market as well. So my colleagues at Brown University, Dr. Roz Murray is sitting over there with some data. So if you're a data nerd and you want to talk more about this data, you can go see Roz on the break. So of course, what would be the impact of neutralizing site-neutral payment for New York at the commercial level? So we are hearing a lot about the effort to MedPAC and others, and then federal legislation, which is somewhat stalled, but federal legislation to push the idea of site-neutral payment in the Medicare program. But New York is really unique in that it's actually studying the possibility of doing site-neutral payment for commercially insured, privately insured people at the state level. So this is sort of a novel effort. And so my colleagues at Brown looked at what the savings might be. And first they just said, you know, one of the things MedPAC has done, the Medicare Payment Advisory Commission, is it's identified dozens of codes, basically services, that can safely be provided in the lowest cost setting, in the doctor's office or in an ambulatory surgery center. There is no reason to pay a hospital more to provide that service, because they are just as good when they're provided in your doctor's office. They've done the work, they've identified those services. So for those services, the average commercial price, the price that privately insured people pay, in New York is $452 for the average type of service, outpatient service, if you get it at a hospital outpatient department, meaning it is billed as a hospital outpatient department, versus $108 in the office setting. That is nearly exceeds a fourfold difference, again, for the same service, same quality, but just because the hospital bought the physician practice and can bill as a hospital outpatient department. So what would New York save if we simply neutralized that payment and implemented site-neutral payment that said, we're only going to pay the lowest cost setting, the physician office rate, for the service because it can safely be provided in the office? That would save New Yorkers, that would have saved New Yorkers $1 billion in 2022 had just these 57 types of services been paid at a site-neutral basis across New York. That's $1 billion in 2022 just to implement this. That's just 1 year savings. And so that's real money. And I think if you have further questions, I encourage you to talk to Roz, to Dr. Murray over there, because she has really started to dig into the numbers. And so if you're like, how can that possibly be? She'll be able to tell you. But these are jaw-dropping numbers.
Yeah, I don't think I will ever get used to hearing that 452 to 108.
Yeah.
That's wild.
Yeah.
So I'm here to talk about the healthcare or the small business perspective. And as we know, healthcare and insurance and costs are increasingly out of reach. Could we pull up some slides? Next one. So we did some opinion polling earlier this year, and it showed, as we know, costs for small business owners are increasingly going up. Insurance co-pays, prescription drugs, hospital visits, you name it. Next slide. And our survey shows that, unfortunately, when these high prices happen, small businesses have to make tough choices. 51% of small businesses increased employee contributions to their health plans. 47% moved to an insurance plan that offered more limited coverage. 29% cut other employee benefits like paid leave or retirement benefits. But it also gets worse. A quarter of folks, when high healthcare costs, not only related to insurance, goes up, they cut healthcare benefits altogether, or they have to increase prices on goods and services, or even eliminate positions and labor costs to make up for these increased prices. So it's really straining the folks who are employing our smallest businesses. Something we've noticed, though, in our research, if you look from 1 year to another, is that the blame is shifting. Before, it made sense. Small business owners blame the insurance carriers. They're the people I pay. It's going up in prices. They're the ones to blame, right? But in this last iteration, we've seen time and time again, the numbers continue to go up, that the blame is shifting to hospitals. Small business owners are noticing that consolidation is affecting their communities, and now they blame insurance carriers and hospitals equally, and prescription drug manufacturers actually last, which is something new we've seen. So folks are opening up their eyes to the fact that it's not just insurance carriers who are to blame, it's the folks eating up our private practices. It's the folks who are charging a ton when they go in for what they thought was a $108 visit, but then got charged $452. So our research shows that, but our research also shows that small business owners overwhelmingly support a number of policy solutions that would increase price transparency, address impacts of monopolies, including banning facility fees and other unfair and opaque billing practices. Site-neutral billing would also address these concerns for small businesses. And like Sophia said, it is the stories that drive it. We hear from time and time again New York business owners talking about their healthcare stories. Something I'm thinking about in this very moment is a business owner just down the street. He owns a flower shop with his wife. Back in 2015, he had his insurance through his wife's freelancer union. And then she got diagnosed with ovarian cancer. And it completely wiped out all of their savings. It completely wiped out everything. They sold their condo in Manhattan and had to figure out how to make ends meet to pay that bill. They had insurance, they had everything. They were doing everything, quote unquote, right, but it still bankrupted them. And that was, I can do math, 9 years ago, and the problem's only getting worse. And so I think about Patrick, who owns the flower shop, or Natalia, who was a veteran ICU nurse and decided to open up her own practice to do nutritional coaching. And she's afraid to make more money because she would get off Medicaid if that's the case. And she's afraid that if she makes too much money too quickly, if she finds too many clients too quickly, she will have to bankrupt herself. So these are real small business owners across our state juggling with these costs, juggling with what it means to be terminally ill, and juggling with the idea of hiring workforces. And these are the heart of the community. So I have many soapboxes, but healthcare is one of the most important things we have to tackle to save our entrepreneurs.
Thanks, Lindsay. I think those stories are particularly powerful. I want to talk more about some of the barriers to passing this kind of policy. It's really rare when you see patients, families, small businesses, employers, unions, and health plans all generally agreeing on the same thing. So what gives? What's the biggest barrier?
I think what we have to remember here is that what's really going on is a shift in the hospital business model. Right? This isn't about the doctors and nurses and healthcare workers in these facilities. They are showing up every day on the front lines of the healthcare system, doing the work that is near and dear to their heart. But this is about a complete shift in the hospital business model. These systems are not the systems they were 50 years ago. We've seen the business model shift in very disturbing ways. They're not funded by volunteers, or staffed by volunteers and funded by donations. These are giant profit maximizing businesses now. And so all of the incentives in the healthcare system are around protecting that status quo. And I would say the biggest opposition right now is the hospital lobby. They have deep pockets. They have a lot of incentives to maintain the business structure as it is. But fundamentally, that model is not aligned with the health and financial security of everybody in this room and every person living in this country, from California to Massachusetts to Texas and beyond. And so this is an issue that affects all of us and is truly going to take all of us together, workers, small businesses, large employers, patients and consumers, and everybody else coming together to stand up and challenge the status quo and be the counterweight to the hospital lobby and the hospital interest to protect the status quo. And policymakers need to hear from us together here in New York, and New Jersey. They need to hear from us in every state and at the national level, because there is a lot of money and a lot of interest to just maintain where we are and to not make progress. But we know that we have to fight, and when we fight, we do win.
Yeah, so one thing I wanted to pick up on, I think these are all fantastic points about sort of the political dynamics, even though it seems as though there's consensus. And there's even where there is support, it's bipartisan, what we're seeing across the country. Healthcare affordability is not a red or blue issue. And so the question is where are the levers of power? And as we mentioned, there are site-neutral payment reforms that are slowly or at least being introduced at the federal level, but I want to encourage states not to sort of wait for the federal governments to take the first move. Because even though MedPAC and Medicare site-neutral payment policy seems to be the sort of laying the groundwork, or at least the framework for what site-neutral could look like across the country, really what we see in health policy and healthcare is that massive reform tends to start at the local and the state level, not from the top down. And states are more nimble, they can move more quickly. Municipalities are more nimble and can move more quickly than sometimes Congress can, and sometimes what we learn from the laboratory of the states informs federal policy as well. So, for example, some states have been moving very decisively in areas that we know that that we've been advocating at both the federal and the state levels. For example, on banning anti-competitive contract terms. We've seen legislation go through in Texas and Nevada. Some states have implemented reference-based prices or rate caps on their state employee health plans, like in Oregon and Montana. Ratcheted back in Montana, but Oregon still has that. Some have implemented limits on hospital price growth through their insurance rate review process, like Rhode Island and Delaware is also looking at this. So one of the things to note here is that yes, while the federal government takes the lead on Medicare payment policy, it really does fall to states to worry about what is showing up for workers, because the rest of even though, yes, the federal government theoretically, through ERISA, has some regulatory power over workers' employer-based health insurance, truly it is the state as the front line, the hospital regulator, the state who is seeing as the purchaser, all of these things show up for the workers of the state. And so I think it's great to have this conversation here, and I really commend New York and 32BJ and all the coalition partners here for being part of this conversation and really pushing the envelope forward, because that is the type of innovative model that, frankly, the country needs.
Yeah, ditto what they said. No, I mean, I am so encouraged by Congress, but Congress isn't going to save us. It's the states, it's the localities. And we need to put pressure on all different types and forms of government. But I'm really excited to see this proposal come through, because it's common sense. It makes sense, and it's going to save $1 billion in a year. It's going to save New Yorkers. That's huge. And that is gonna, be funneled back into our communities, funneled back into our businesses, funneled back into our consumers. And if we don't do this, there's so much at stake. I'm gonna do a little corny practice I like to do sometimes, but if you're comfortable, I'm gonna paint you a picture if you wanna close your eyes. And I want you to think of all of your favorite small businesses. Maybe it's the Georgian restaurant across the street, or maybe your kid's childcare provider who makes latkes over the holidays. Now, with the cost of healthcare increasingly rising, maybe your kid's childcare provider will need to leave the field for a job that can share the cost of healthcare. Or that favorite Georgian restaurant may need to close its doors because it simply cannot compete with the Walmart down the street. What would happen if all of your favorite small businesses cannot afford healthcare? What would happen if all of your favorite small businesses close? And now you can open your eyes. And I know that's a little dramatic, but I'm a firm believer that every single community has a heart and a soul, and that soul lies with small businesses. And it's true. Out of every dollar spent at a small business, 2/3 gets funneled back into a community versus the 30% at a national retailer. The money small business owners spend stays local, and they also hire local. They view their employees as family and take care of their own. And that's why I never hear small business owners say they are excited to cut healthcare costs for their employees or furlough people. They have to look people in the eyes and make those decisions, knowing that, God forbid, if my employee gets a terminal illness, that's on me. And so I think the cost of rising healthcare is a way, if we are able to tackle it, it's a way to preserve the heart of the community. Because if we don't, how boring would our neighborhoods be? We would have the same Walmarts, the same Starbucks and Chipotles down the street. And that's not what community is. That's not what neighborhoods are. So truly, what's at stake is our character. What's at stake is everything. And I know healthcare is just one aspect of the problem, but small business owners speak for themselves. It's the biggest aspect of small business ownership.
That's fantastic. And shout out to all of our local coffee shops for making this event possible. Okay, get all of your questions ready in the audience because I've got one last question for these folks and then we'll open it up for you. It's a double whammy. So it's really, if we can't pass healthcare pricing reform, let's forget about Congress. At the state level or at the local level, what do we think are the implications of that? And then what's one thing that each of you would ask the audience to do with the information that you've shared today?
Okay, I'll go first. I'm going to answer your question with its minor pivot to just say the point about Congress, which I would be remiss if I didn't talk about that here. And you guys, there is a major fight happening in Congress right now to enact price transparency with teeth, which means actual penalties for hospitals that don't comply with unveiling their prices to consumers and to the public, and enacting a number of other types of transparency provisions around billing, making sure that there is actually a site-neutral provision in Congress that has been passed with overwhelming bipartisan support out of the House last year. And there is a fight happening at the end of the year in Congress, a negotiation in the lame duck session, where we have it's going to be a sprint, but it's an incredibly important moment. And there's more work to do to get those provisions over the finish line. We need the Senate to act. There are a number of Senate proposals on the Senate side too, in different on site neutral and price transparency that are really good, really pro-consumer. But we need to get it done at the national level. And I'll pivot to the call to action, which is join us, obviously, here in the fight in New York, but also on the national level. Families USA has a booth over here. If you have a story, if you want to join the fight at the national level, we run multiple coalitions. Many of the partners are here today in the room in partnership with folks. Tell your story, get on our listserv, and join the fight, not only in New York and New Jersey, but also in Congress. They need to hear from you. Working people have incredible power in the political discourse and the political discussion. And yes, it's hard to have a lot of faith in Congress. It is incredibly partisan, but as I think Aaron mentioned, this set of issues is crazy bipartisan. It is insanely bipartisan. The biggest opposition is actually not partisanship, it is hospital lobby. And the way that we overcome that is together, all of us joining forces, telling our stories, showing up, organizing, challenging the status quo. And so if you're energized, I hope you are, because I'm ready for the fight, you guys. Come and join us and tell your story, and we'll find ways for you to get in the fight. And appreciate every single one of you, so thank you.
I don't have a whole lot to add to the great remarks that have already been made throughout the day and on this panel. And so I would emphasize that this is an area where there's both sort of bipartisan upswell, there's a coalition, a multi, sort of interest group coalition, and the data is really behind you. And I think that is something that is sort of worth noting. And so, to prepare for the inevitable pushback from the hospital saying, this is going to force us to close our doors, or this is going to, and being armed with what's happening is already harming access and costing lives and livelihoods. So I think that's really just an important, just to say, great job so far for even having this conversation. More work to be done.
My favorite fun fact is the fact that small business owners are the most trusted community members and voices. And we have data to back it up. I'm not just spewing it. Pew does a study every year. Who is the most trusted voice? And it's small business owners, more than churches, more than financial institutions, more than schools, more than the military. And something I always, for any political fight, but particularly in healthcare, always include small business owners. Time and time again, if you include the voices of small business owners, and sometimes folks get a little wary because they forget small business and big business are different. They are very different. But include them. It was the small business owners in 2021, that helped pass the Colorado option, which was a lower health care plan that is now enacted in the state. And it was also 2 years later, small business owners who spoke up about hospital facility fees and figuring out how to make them more transparent and limiting them. So they have a hugely powerful voice, and Small Business Majority is an organization that tries to uplift those voices. So please include them in these critical conversations, and you will be successful. You will see those things pay off tenfold. Because at the end of the day, again, small businesses are the heart of every community.
Thanks, Lindsay. And I would be remiss if I didn't end our comments with an ask to join our Coalition for Affordable Hospitals. If you are interested in pushing for site-neutral payments in New York State, you can see us over at the table to the right. We will be, helping with the Fair Pricing Act in the months to come. So please join us. And now we'll open it up for questions, but I realize some of our mic runners may need to come get the mics off the stage. Oh, Spencer, you've got one. Okay.
My name's Reverend Peter Cook. I'm the Executive Director of the New York State Council of Churches. We represent 7,500 small businesses across the state. Those are called local churches. One of those denominations, of course, is the Presbyterian Church. It's a little disturbing to us that a Presbyterian hospital forgot where it came from. So, just gotta say. Right now, in the Presbyterian Church, as it turns out, they are having to dismantle their nationwide health plan and telling their local churches that they have 3 years either to stick with a plan nationally which will double in price or go onto the market and shop around just like our flower shop owners and all of that kind of stuff. So I just want to put that out there that when we're talking, please remember all the faith communities, most of those places have 1, 2, 3 employees who are paying through the nose. It really hurts their bottom line. And they're also your strongest advocates for doing what we do, which is to try to change policy. And then I would just add into that all of the nonprofit sector, which usually has 1, 2, 3 employees. Most of these are those who also really get slammed with these healthcare costs. So, thank you.
Thank you, Peter. Peter and the Council of Churches have been excellent advocates for healthcare affordability, so fighting the good fight. All right, Mike Renner's next question.
Hi, my name is Sidney Haytoff, CEO of Michi Health. Wanted to ask what's being done and what do you all think could be done to help guide patients to other sites of care outside of the hospital where services treatment is considerably more affordable. For example, the colonoscopy service that was mentioned earlier, $4,500 was the affordable rate when I thought that was going to be the unaffordable rate. We have numbers, if not scores, of practices offering colonoscopies for $1,500 on our platform. And so I guess the question comes down to how do we do a better job of guiding patients to the more appropriate settings, depending on the type of service, where we're not giving back to the hospitals that have been screwing us, better educate in general.
I'll jump in and just say, I think one of the challenges is that consumers, patients right now are completely blinded to the cost of care, right? There was federal rules that went into effect in 2021 that required all hospitals across the country to be unveiling, disclosing, to be sharing the underlying price, the actual price in dollars and cents of healthcare. But we know to this day, several years into implementation, the vast majority of hospitals are not complying. They do not want to share the prices. And so, unfortunately, without stronger enforcement and compliance of that regulation, it's very difficult for consumers to have the cost and price information that they would need to inform one side of that equation, which is like, where can I get the most affordable care for the service that I need? The other piece of information that we need that we also don't have at that level is the quality. And so that is part of what Families USA is working on with a lot of partners in the room at the national level, which is we need much better information about the price of care, the quality of care together, so that purchasers, whether you're a consumer, you're an employer, and other, can actually see what the value is for the care that we're getting and actually make more informed choices. But I will tell you that the biggest opposition to this is that hospitals don't comply. We've got federal rules on the books requiring them, which is why we need states to take action, to put teeth, actual stronger enforcement mechanisms, codifying some of that legislation into state law if they can, with some real enforcement and oversight mechanisms. And we need the same thing at the federal level, which is what Congress is negotiating, debating right now, taking those federal rules and putting them into statute and making sure that there's a strong enforcement mechanism. So unfortunately, it's imperfect, but that's hopefully a call to action for why we need a lot more activation from folks across the country in the fight to take this on.
Something I will add really quickly is a model I've seen that works across the country is if you educate employers, particularly small business, but if you educate employers, they are able to tell their employees, hey, I know you're going in for a colonoscopy. Have you considered X, Y, and Z? They often are a really great messenger, particularly for those smaller businesses that are able to provide healthcare because they also have a vested interest in keeping costs low.
Do we have another mic?
Yeah.
Another question?
Greetings.
Back in the back.
Yes, greetings. My name is Dr. Marcus, and I'm the community director and advocate in Brooklyn. For years, I've been advocating for our hospitals in Brooklyn. Many of them have been closed because of lack of funding. A few years ago, they tried to close Interfaith, but prior, they tried to close Brookdale. I fought to keep those two hospitals open. I was unsuccessful in keeping St. Mary's open. These are hospitals in our community. And when we speak of funding, I realize that, yes, the fundings are there, and it's coming down, but instead of coming down to the needs of the hospitals to keep them afloat, keep them viable, I noticed that most of this funding goes to the developers who coming in claiming that they want to help and taking most of those resources out. How could we divert those funding directly to the hospital and not to the developers?
So I'll take a crack, and then you should totally, okay. I'll say one of the things we're seeing is, in terms of developers, is a lot of private equity and angels investors coming in and buying up hospitals, and it's a business proposition. And I would urge us to be extremely skeptical of the role of private equity in the healthcare system. It is their business model of a short-term profit and purchase and profit and sale is completely incompatible with making sure that people and communities have access to affordable healthcare that's going to meet their needs and the needs of their families. One of the biggest challenges in taking on in private equity in particular, and I'm not sure if that's the case with the story you're telling, is that it's a giant black box. We have very little insight, almost none, to actually understand who owns the hospitals. And with private equity, we see that the transactions are occurring so frequently, every couple of years, right? And there's so many changes in ownership that we actually don't know who owns it sometimes. We don't have data into that. So one of the biggest things, it's actually a piece of legislation that's being considered at the national level in Congress, is actually getting some transparency about who owns these systems, so we can actually inform regulators and to have better insight and oversight into challenging some of these, the role of private equity in some of these mergers, acquisitions, and making sure we have a much stronger oversight over the markets.
And I would add to that there's a lot states are doing. State healthcare transaction oversight is growing the authority to look at major material change transactions. And I would add many states are starting to contemplate adding closures to the list of what is considered a material change transaction. So would be a sale leaseback of the land or the major assets of a health facility, and that would also trigger health department and attorney general review, study, market impact study, and also eventually the ability to block or place conditions on any major transactions that might have an ill effect on the public. And so I think that states are realizing they cannot rely sort of on transaction oversight from an antitrust review from the federal government just because of the lack of resources, but also that states are dealing with different and communities are dealing with different problems of consolidation than just more mergers. But now we're seeing the closures, and the closures are and the stripping of assets, and the stripping of assets and the closures of healthcare are sort of like the now problems of consolidation that states are now moving in, I think, at the forefront to try to get a handle on.
Thank you. I think we'll take one more question and then we'll go ahead and end. So right here, I know you've had your hand up.
Hi, my name's Connie DeMary. I'm a physician. There have been an avalanche of physicians joining health systems or private equity. And this was almost by design created by the federal government because we couldn't deal with the cost and complexity of MIPS and other federal programs. So, and it's really, really sad because small practices have been shown to keep people out of the hospital better than these mega practices. How can you address this, undo this?
Yes, it's certainly not the independent physicians that are selling out to the health systems or to private equity. They are being forced into this untenable situation where it's impossible to run an independent practice anymore. And so one of the other types of legislation I've worked with NASHP on are strengthening the existing, it's on the books in like 35 states, the corporate practice of medicine doctrine, which was supposed to limit corporate control over physician clinical decision-making and professional autonomy. They're on the books, but they've been circumvented and contracted around for decades by powerful health systems, private equity, and other corporate investors. So one way to get at this problem is to say, yes, we understand physicians need the administrative support to run practices. They cannot go it alone anymore. However, the private equity company, the Optum, the payer, the health system should not be imposing and taking control over the practice to the extent that it would then start to interfere with clinical decisions, would interfere with physician-patient relationships. And there are ways to do that, but but it's I understand that the pinch.
Sadly, MIPS has not improved quality or decreased costs, yet it's put us all out of practice.
Yeah.
And made us employees, which is really a disaster for patients.
Yeah, I'll just say two quick things. One is I think the evidence supports that MIPS is not working as it was intended, and so there are conversations about what do we do with MIPS and how do we replace it with something that's more value driven. So, but I completely agree with you. It's an incredible burden, and I do want to just say in terms of what you're talking about, in terms of there is this financial incentive, and to bring it back to the topic for today around site neutral payments. And it originates in the Medicare program, and it's that Medicare pays more for the same services performed in an outpatient department. That creates a massive financial incentive for big systems to come in and purchase the physicians, bring them into their business model, and rebrand, push them to outpatient care so they can get the higher reimbursement, which is why if we get the site neutral in the national level and in the states, we can eliminate that financial incentive and give physicians, independent physicians, a chance to survive. But there are a lot of other policy solutions that have to be implemented to preserve the independent physician practices. Absolutely.
Thank you. And I think this afternoon we'll hear from Peter Lee on a pretty innovative model that they've done in California's public plan to really use a pretty lean set of quality measures that are aligned across systems so that they can avoid a lot of this kind of quality exhaustion among providers and help get an aligned delivery system moving. So I'm really excited about that. And we have time maybe for one more question I see in the back. Cynthia.
Thank you, Ron. Thank you. Excellent panel. Cynthia Fisher from patientrightsadvocate.org. I think I would ask the panel of, and I applaud on the desires for site neutrality, and I would seek to say that the employer and the union plans need access to full-blown systemic transparency, because if you do site neutrality and you don't have access to all the prices and the billing and payment information, then you don't know where any of those savings can potentially be. So there's an elephant in the room that I haven't really heard anybody mention yet. And to speak of the elephant in the room is to say that the insurance carriers and acting as third-party administrators have been withholding access to the billing and payment data. So when we can't see what the provider is actually paid out of our plan and what that spread is to Cigna or Aetna or Blue Cross or United, we don't know how our workers are being harmed with overcharges. And the beauty and the beginnings of this price transparency in the hospitals and insurance companies, even though they make it really difficult, and we only have 34% compliant in the hospitals, is that Kraft Heinz sued Aetna for $1.2 billion. Aramark sued Aetna for $1.6 billion. Ford sued Blue Cross for $1 billion. And we saw a lawsuit in California where we just started to parse through the actual claims data that came out of discovery. And what we saw is Cigna and MultiPlan kept on average 3 to 3.5 times more than the provider hospital was paid. 3.5 times more than the actual 835 data paid to the hospital. So if we're not calling out that the insurance carriers and the TPAs are all part of this, that we have to systemically see the hospitals and every single middle player and the insurance carriers who are in cahoots because they're withholding this data, as are the hospitals. So I guess I ask this panel, as you look to implement this important state law, how do you see the accountability to get access for the employer and the union plans to all of their money spent so we can negotiate to lower the costs and be competitive on the global market? Because at 2.5 times more, our jobs are going overseas. And God bless the unions for all the fighting that you're doing here, but many of the jobs, you know, when John Deere went to Mexico for its manufacturing, Cargill's sending to Costa Rica its accounting department. We cannot afford to lose our jobs. So I guess I ask, it's so critically important, how do you see holding the insurance industry as third-party administrators and all the middle players, as well as the hospitals, accountable for systemic transparency?
Yes, I think that's a great question, and I'll go ahead and answer it. And that I think, in addition to any sort of provider price cap going on, ideally this policy, the Fair Pricing Act, would also be holding insurers accountable for the prices that they are paying to those providers and making sure they are not paying above that cap and that they are not holding any of their members or participants responsible for prices above that cap. And so we think that will give employers, unions, real motivation to access their claims data and to really be looking at the prices that they are paying because they know they can do something about it afterward. And Claire, I'll go ahead and hand it over to you for our next speaker. And thank you all so much.
Amazing. Again, more amazing, powerful women. Thank you. So we're in the home stretch. We have our last speaker of the morning, and that is Reed Showalter, who is the Senior Policy Advisor to the White House National Economic Council. We started the morning talking about the role of the Federal Justice Department. We've evolved through city, state, a number of different perspectives. So we're going to bring it home before lunch, back to where the White House and the administration is. But a couple notes while Reed makes his way up. We do have, I do want to acknowledge that we have New York and New Jersey Coalition for Affordable Hospital partners here, and we appreciate their ongoing engagement. As we've heard from everyone today, it takes more voices to make this work. New Jersey PBA, New Jersey CWA, communications workers, DC 37, and PEF. So thank you all for coming and engaging in this process with us. So Reed, before he joined the National Economic Council, worked at the Department of Justice, working on competition, so he brings that unique perspective, and is a private antitrust lawyer. So we really, Reed brings a valuable perspective of so many different angles on how our healthcare industry is affected by things like hospital prices. Thank you, Reed.
Hi, everyone. Thank you, Claire, for inviting me, and thanks to all of you for the gracious welcome. Maybe we can raise this. Height problems. It's a real privilege to be here with you all. You all are the front lines of the work on policy, the actual health expertise, and the work of building power to fix the problems of consolidation in our healthcare system. As Claire said, my name is Reed Showalter. I'm a senior policy advisor at the National Economic Council, where I lead our competition work. And I'm here because President Biden believes that healthcare is a right, not a privilege. But every year we spend almost twice what our average peer country spends on healthcare. And it's not delivering us better results. You look at our peer countries, our life expectancy is 4 years lower than the average peer country. We have the highest maternal mortality. Hospitalizations for diabetes and hypertension are about 50% higher than OECD peer countries. And our doctors are extraordinary. They're some of the best in the world in advanced medicine, at avoiding post-surgery complications, at treating diseases like breast cancer. But for too long, corporate special interests and trickle-down economics have made healthcare a game of extraction. Our healthcare dollars are increasingly being swallowed up by a shrinking number of payers, providers, and dominant intermediaries that have monopolized their way to power. One research org recently put out statistics that show just how deeply consolidated almost every healthcare market is. Just by way of example, the top 2 companies control 63% of orthopedic products, 69% of syringes, 75% of IV solution, 76% of dialysis machines, and over 93% of dialysis centers. The consolidation in healthcare markets has only accelerated in recent decades. Too often, this has led to higher costs, worse quality, and less access to care, particularly in rural areas. For example, one review of hospital mergers in consolidated markets found that prices tend to increase by more than 20% following a merger. And as consolidation kills off independent physician practices, patients of the remaining large hospital-owned practices pay more than $300 more for similar care. Meanwhile, private equity has swept in, buying over $750 billion worth of physician practices, nursing homes, hospices, home care, mental health treatment centers, travel nursing businesses, and more. And so on top of the harms of consolidation, some of the aggressive profiteering by private equity and private equity-owned practices can lead to even higher patient costs and worse quality care. All of this is a policy choice. Past administrations from both parties have tolerated or even encouraged healthcare consolidation. A lack of enforcement of the antitrust laws, regulatory incentives to consolidation, and in some cases, simply a lack of attention or awareness about the harms of consolidation have made this problem worse. In one particularly egregious example, some old 1993 guidance by the DOJ and the FTC suggested that a lack of antitrust enforcement would be, quote, especially helpful to small rural hospitals. Just want to let that sink in. They said on paper that hospital mergers are good, especially good for small rural hospitals. We've seen the consequences of that mindset. Now, I don't want to preach to the choir here about the consolidation problems in these markets. You all know. The good news to share is that President Biden came into office acutely aware of the danger of monopoly power. That's why in 2021, the president signed a historic executive order to establish a whole-of-government effort to promote competition in the economy, including and especially in healthcare. And since then, we've been doing the slow, painstaking work of turning the ship. The first step in that process has been getting the right data to the right people to properly enforce the laws that are already on the books. In many ways, healthcare consolidation has been a problem that could be solved by more and better equipped competition cops on the beat. That's why HHS appointed its first ever chief competition officer. It's why the DOJ Antitrust Division launched a task force to address collusion and monopolistic practices in the healthcare markets. It's why HHS, FTC, and DOJ signed a formal partnership to share data and resources to identify anti-competitive transactions that might otherwise evade review by the enforcers. DOJ and HHS entered another independent collaboration to deepen that coordination. And these agreements require that the three agencies work together on case referrals, reciprocal training, policy initiatives, data sharing, etc. CMS, for its part, has made ownership data available for the first time ever on hospitals, nursing homes, hospice providers, home health agencies, health centers, and rural health clinics on its website to help shed just a little bit of light on the ownership trends in healthcare and make it easier to track that consolidation and ultimately enforce. And DOJ, FTC, and HHS launched a new one-stop shop portal, healthycompetition.gov, to give people an accessible point to submit complaints. Across all this work, the agencies have put historically substantial attention on healthcare consolidation. And again, that's just one part. The administration has also deployed all available tools to directly address the unfair and anti-competitive costs of healthcare. Under this administration's Inflation Reduction Act, we announced that Medicare was able to directly negotiate prices for 10 top prescription drugs that will save north of $6 billion for Medicare, and more importantly, over $1.5 billion for American families. The administration, meanwhile, has expanded access to eyeglasses. They made hearing aids available over the counter, saving an average of $3,000 per pair. They challenged the illegal listing of patents on the FDA's Orange Book, things that monopolists use to protect products like EpiPens from generic price competition. HHS issued a rule that was mentioned just on the panel just now that put a nearly 20-fold increase on the penalty for hospitals that fail to disclose their prices to the public. And the law enforcers have, of course, shown that they are committed to taking on price gouging wherever they see it. On the IP side, we've seen over the years that taxpayers have spent hundreds of billions of dollars to fund the research catalyzing discovery and development of new transformational healthcare technologies. But all too often, that research goes unused, or a private company takes it up and they deploy it and charge prices that put it out of reach for the people that actually need it. That's why the Department of Commerce and HHS released a proposed framework for agencies that would clarify that the government can march in on the patents we all funded on things like drugs and medical technology when the prices are so high that it's inaccessible to the public. And the FDA and the USPTO announced for the first time that they're going to work together to intensely scrutinize those little incremental changes to medical patents that unjustifiably delay generic competition based on trivial changes. And we haven't even touched on the historic enforcement that the antitrust agencies are bringing to stop and undo healthcare consolidation and monopoly power. Now, I can't steal Ryan Danks' thunder, but these agencies have been doing a bang-up job. The FTC, under this administration, has challenged nearly 20 healthcare mergers, many of them hospital mergers, and the DOJ likewise has enforced the antitrust laws against everything from acquisitions by major payers to major pharma companies that have been fixing prices. And the agencies have bolstered this enforcement agenda with merger guidelines that clarify the harms that hospital roll-ups and purchases of smaller competitors, and the harms that mergers that entrench dominant positions in markets like healthcare cause. And finally, yes, the DOJ and FTC rescinded that old guidance that said rural hospital mergers are good. Now, there's obviously more to do. The administration recognizes that healthcare is still much too expensive, much too consolidated, much too inaccessible. But we've taken the first step in fixing a problem. We've recognized we have a problem. Our problem is monopoly power in healthcare, monopoly power in the provision of care, monopoly power in insurance, in drug markets, in the middlemen that negotiate everything out. It is still much too easy for vertically integrated providers to game the financial guardrails we've put in the system. And there's too much room for abuse by powerful middlemen like PBMs and GPOs that are supposed to be negotiating prices down for the rest of us, but are too often working to secure kickbacks and incentives that only serve their bottom lines. On the bright side, we've also taken the second step to fixing a problem. We have started to fix the problem. The administration is laser focused on continuing this fight, and it's a sign of the importance of these issues that you all are here today to discuss and to build power and to take the next steps. And I hope you think of the administration as a partner in that effort. We want to keep hearing from you, and I hope you keep pushing us to do more. We need to keep doing more to cement the gains that we've made so far and to continue to keep moving forward. So yes, there's more to do, but we are starting, finally, to win. Thanks all very much for having me. It's been an honor to talk to you all.
Thank you so much. That was excellent. Thank you so much. So, I'm the only thing standing between you and lunch. So I won't keep you anymore. But this afternoon, we'll come back. We have about an hour for lunch. It's downstairs on the 4th floor. It's a cooler room, I promise. And so there are tables set up. You can enjoy your lunch and some networking. The afternoon, we're going to look at some very specific tools that we've launched this week to allow more contracting transparency along the lines of some of the things that Cynthia Fisher mentioned in her question, more pricing analysis, as well as the work that some really interesting purchasers are doing to tackle this issue head on. We don't always have to wait for government action. In fact, we shouldn't wait for government action. So please come back in an hour and continue this dialogue. Thank you.
Good afternoon, everyone. This is your 7-minute reminder that you need to come and sit down. Please start to take your seats for our afternoon of fun and excitement. If you are a member of the 32BJ Health Fund, please help collect folks to their seats. They just ignore me. Thank you. I appreciate that. Good afternoon. We're now down to like your 5-minute warning or so. So please find seats. I know our vendors are amazing. We appreciate our thought partners, but please come find a seat and talk to them afterward. That worked too. All right. Good afternoon, everyone. Welcome back to the afternoon. Just wait. Oh, look at that. See, I just keep talking. Eventually, everyone else stops. Good afternoon, everyone. I know it's just after lunch. We had some delicious food. Energy might be a little low. I'm going to try to perk us up a little bit because we've got an amazing afternoon to bring everything to a close. My name is Cora Upsall, and I have the privilege of being the Health Fund Director for the 32BJ Health Fund. That means, very candidly, this event would not exist if it wasn't for my team, not for me. But I'm kicking off this afternoon because one of the things we try to do in this event, and as Claire has mentioned, this is our third event. It started with a webinar 4 years ago, and then we have now on our third in-person event, is that we try to marry the politics, the policy, and the benefits. And it's because we believe as employers, we can't just care about benefits. Because without policy to help us enact the things that we can't do in our benefits, and without the benefits to support the policy, we're all just going to keep paying more for health care. So I want to spend just a few minutes talking a little bit about us, the 32BJ Health Fund, and the Labor Industry Cooperation Fund, and really how we are looking to push beyond the status quo. How do we talk together and through collective action really make some concrete changes as purchasers in healthcare? But first, numbers. Anyone who knows the 32BJ Health Fund knows that we live and die by data. My entire team has heard me say this multiple times. Any public campaign, no one ever questions our data, because I think we probably check it multiple times. It's more than just checking it twice. We probably check it 37 times. But it's because data is what drives our decision making. And it's really clear. The numbers show what the data shows, what the data shows. We spend last year we spent $1.4 billion on healthcare. This year, we're looking to spend 1.5. Every year, we're spending more. And so we know that we have to be good stewards of this benefit, in part because our union members pay nothing in this benefit. It's 100% paid for by the employers of the benefit. There's no in-network deductible and low to no co-pays. But we can't keep doing that if our healthcare trend continues to go up. We know that of that money that we spend on healthcare, 55% goes to inpatient and outpatient hospital care. Just 2 years ago, that number was 44%. It's higher than the New York average, which I think is about 51%. Someone over there on my team is going to tell me what the real number is if I was wrong. And the national average is 44% on inpatient and outpatient hospital prices, which is why we know we're focused on that. You heard it from Manny this morning. Healthcare costs make up 37% of total compensation. And over the past 10 years, I gotta look at my slide, wages have gone up 54% and healthcare has gone up 230%. That's untenable. So we look to make changes, and we fight hard to make changes, because the employers in the room, you all know, it's hard to make change. It's especially hard when we're left with market dynamics and market power that stands in our way. As Manny mentioned this morning, and as you've kind of heard from our other speakers, we are in a marketplace where the power is not centered on the employer, the self-funded employer who's paying the bills. For us, we went through an RFP. We spent 18 months doing it, and our choice was taken from us because of the power dynamics that exist outside of our contract. But we don't stop there. But I do say that that is what guides us and motivates us. But here's the other piece, right? There's the power, there's the member piece that motivates us. I love this slide. We're calling this our pizza graph. And it's that we did the math, again, back to data. We spend over 40% of our healthcare spend on 5 medical centers systems here in New York City. Over 40% to just 5. What that means is that is equivalent to a little over $7,200 per employee per year on just 5 hospitals. And similar to Zach Cooper, when he showed the car, we wanted to make this real for us. That's pizza night for these families every single Friday for 3 years. That's commuting to and from work every single day for 5 years, or 1 year of college tuition at the City University of New York. So again, this is real money to our folks. So how do we fix it? We fix it through the intersection of benefits and policy. On the benefits side, we look at our network design. We tiered our network in 2018, and then in 2022, we removed New York Presbyterian from our network due to anti-competitive contracting terms. We consistently work on what our contract can look like and gaining power through the rights that we can get in our contracts with our vendors. And then on the policy side, what do? You're here. This is one of the things we do. We have public campaigns. We talk about we use our data to talk about the impact of real change to members that these healthcare dollars could mean. We talk about how we spend $13,000 on average for a colonoscopy at New York Presbyterian and $3,500 elsewhere. And we also do legislative efforts. You heard about that this morning. You heard from Senator Krueger and Assemblywoman Jackson and the Fair Price Act. You heard about the Office of Healthcare Accountability in the City of New York, first of its kind. You've heard about New Jersey and the work that's happening there to fund their Office of Healthcare Accountability. And we look at that because we recognize, again, benefit design alone will not solve the problem of affordability, and we have to mix that with policy. So why am I up here talking? I've just said everything that everyone else has said. But I'm up here because one of the things we want to do is we want to give back. And we want other people to have access to the same tools that we have. We understand that true change comes through collective action. And that means all of us in this room coming together and making change, demanding transparent prices, as Cynthia Fisher has talked about, demanding site-neutral payments, as the panel this morning talked about, demanding access to high-quality care at an affordable price. But not everybody is as big as 32BJ Health Fund. And I recognize not all of you have had your data for 20 years and have an incredible team of analysts. So we've developed 2 tools that today on our website we are launching free to use for anyone. The first is a healthcare cost tool. This tool is meant to be able to be a benchmarking tool for you to use to figure out how much are you overpaying in healthcare. As long as you know how many employees you have in your state and how much money you're spending on healthcare, our tool will be able to tell you exactly how much money you could save if you paid different percentages of Medicare, or even if you just paid the break-even rate. We've used data from SAGE, the SAGE tool, from NASHP, from the RAND tools. We've combined this into an easy-to-use report that you will be able to go into the offices of your financial offices and say, here's what we can do to save money. But one of the things we've learned is that's about rates. The other tool we're releasing today is about rights. And we learned that one of the best ways for you to be able to have the power to really own your own benefit is through the contracting process. So today we are releasing a medical contract template that we want everyone to use. This template has 15 sections, a lot of information, and the idea is that when you go out to RFP, because we know it's hard, but when you go out to RFP, you have your data that you know how much you're overpaying, and then you're going to take this contract and you're going to say, all right, carrier, I need you to fill out this, I need you to redline this contract. Because if the contract starts with you, you hold more power. We did it. We did it in this year, and even with those headlines where we ended up staying with Anthem, we are in such a much better place because of this journey that we went on. We believe based on our new contract that starts in 2025, we will save tens of millions of dollars in contract terms alone. Super nerdy, boring things that I love. So today, I challenge everyone in this room, go to our website, play with the tool, download our contract, use this, because we do believe if we come together, we will all make a difference and change the fundamental structure of our healthcare. And so with that, the way we move on next is to talk a little bit about other folks who have changed the fundamental structure of healthcare. And so I'm going to invite up Claire Brockbank, who you've all heard, but before she comes up here, I want to tell you a little bit about Claire. Claire is my Director of Policy and Strategy. She's been with us a little over 2 years, and she is the reason we are as large as we are today. She called me up, she sent an email about 3 years ago and said, hey, if you're ever interested in some consulting help, I'd love to help what you guys are doing, it's really cool. And I said, no, but I have this job. Are you interested? And she relocated her entire life from Colorado and moved to New York City to live out her own personal dream of always living in New York City, and has built an incredible, brilliant group of people. And with Claire, we have been able to build a tool, release a contract, and fight high hospital prices. So with that, I'm going to invite Claire up to the stage, and she will introduce the rest of the panel. Thank you.
I'm going to actually just have the rest of the panel come on up. Thank you, Cora. That was really nice. She's right. I reached out to her in February, and I started work June 1st. Okay, while we get the panel up here, I did want to acknowledge that Assemblyman Steve Raga from Queens came in a little while ago, and we so appreciate his presence here. I don't see him in the, oh, there we go. Thank you so much for coming and spending some time learning with us. Okay, we have everyone? Great. So, I feel like I need to be taller. I've been standing all day. The process this afternoon, this is where we get into sort of the nitty-gritty of things that you can do to make a difference. Cora set us up nicely. I'll introduce our speakers. We're going to have each of them speak for a little bit. I'll lay some context, and then we'll have a bit of a discussion amongst ourselves, and then we'll open it up for some questions from the audience. So that's the lay of the land. So what we're going to be doing is looking at this panel. One of the things that is amazing about it is that they are all purchasers that are in different parts of the country, different sizes, different models, are all doing things to change the way we drive more accountability and more affordability in the healthcare market. So with that, I'm going to start with Sean. Sean Greminger is the president and CEO of the National Alliance of Healthcare Purchaser Coalitions. So he represents a whole lot of purchasers. And he has worked for decades, well, many years, a lot in the healthcare arena.
20 years.
What's interesting is he's an advocate for purchasers, but he also exhorts purchasers to use their voice. He's always trying to do the train the trainer model, if you will, and that's deeply appreciated. Because Sean has worked for hospitals, which we don't hold against him because they are important institutions, but he's worked for many different facets of the healthcare system, so that perspective on the ecosystem is really a very powerful perspective that helps us as purchasers. Then we have Rosa. Rosa Novo is with Miami-Dade County Public Schools. So, third largest board in the country. She has been at the forefront of consistently and steadily introducing innovative solutions for her members in an incredibly challenging environment. So she's got a union mix and a non-union mix, and in a state that has a very different profile than New York. So we're going to hear about some of the things that she's accomplished and what she's done. And finally, an old friend, Peter Lee, who's with Stanford University and a CalPERS consultant. In the capacity at CalPERS, I don't think he would say this, but I will. He was part of the architect of their new purchasing solution, which really broke ground in terms of holding two different vendors accountable for both cost and service, and setting some amazing price growth targets that the vendors agreed to. But one of the things I love about what Peter did was that instead of saying, I'm going to invent my own targets and my own quality measures, he said, how can I leverage the really hard work that the state of California had done in creating an office, in creating state benchmarks, and in creating state quality metrics? So they used those, they piggybacked on those. It's a great example of a purchaser both purchasing and supporting the policy environment. So that's our panel. And Sean, why don't we start with you? We'll go down the row.
Sure. So, Sean Grimminger again. Thank you very much for the invitation. It's really a pleasure to speak at this conference. I've been looking forward to this for a long time. So, the National Alliance of Healthcare Purchaser Coalitions, yes, I know the name is too long, it's a national organization that represents about 45 regional employer purchaser coalitions around the country, each of which then represents employers and purchasers in their area. All together, we need updated numbers, but something north of 17,000 employers, 40 million covered lives, so a substantial portion of the self-insured market. Rosa is the board chair of the Florida Alliance for Healthcare Purchasing. Get that largely right?
For healthcare value.
For healthcare value. Peter or CalPERS is the largest member of the Purchaser Business Group on Health out in California, where I used to work. Of course, 32BJ is a member of the Northeast Business Group on Health here in New York. So there's a very good chance if you're an employer or purchaser, you may be a member of a coalition, and if you're not, I'm going to try to convince you should become one, because we can be a significant partner in helping you in a lot of different ways, in particular around the policy space, which we'll be talking a little bit about.
So great, thank you. So good afternoon, everyone. As mentioned, my name is Rosa Novo. I'm the Administrative Benefits Director at Miami-Dade County Public School and the proud board chair of the Florida Alliance for Healthcare Value. I would like to first thank the 32BJ, Cora, the entire team for this opportunity of not only sharing the stage with these amazing two individuals and lady, but also for the partnership, for the opportunity of continuing to voice the concern on behalf of the employers, and mainly large public employers. As previously mentioned, Miami-Dade County Public School is the largest school district in the state of Florida. It is the third largest in the nation. Our healthcare expenditure is $441 million and facing a $37 million increase for next year, which I have mitigated $11 million, which later I'll explain my strategy. And it is financially a challenge for us because we cannot pay the salaries our employees deserve and need to purchase a house in Miami, and I was so happy to hear that before earlier today in New Jersey as well. It's almost impossible. Our bus drivers make $14,000 a year. Who can purchase a property with $14,000 a year? Our teacher's starting salary is $50,000 a year because we are funded the same way that all the other 66 school districts in the state of Florida are funded. And yet almost 60% of our property are located in what's called the Hurricane Alley, which we pay a lot for property insurance, and it all comes out of the same pot of dollars. So looking forward to our conversation today. Thank you for all the speakers. I was sitting all the way in the back and I was like, oh my God, I was so upset because a lot of this we've been discussing for years. And thank you, Sean, for also supporting us. But employers need to take action. It's not only the policy. So looking forward to our conversation today. And again, thank you. Thank you for having me.
I sort of have an academic hat at Stanford, but mostly I've been a purchaser. I've also worked in the Obama administration helping set up the Innovation Center, and I used to run a large purchasing coalition. So I'm anchored in purchasing. What I'm going to talk about is what's happening at CalPERS. CalPERS is a very large public purchaser. Unlike my colleagues, I'm going to do a few slides, mainly so you can get them later, because you can get all the slides through 32BJ. So I'm going to flash through some slides, or am I not?
No, so can we make sure Peter Lee's slides are loaded?
Forget the slides, don't need them. Okay, but I will speak to them, and they'll appear magically in the slide set later. That's okay, really, you don't need it. No, forget it.
You can get them, but we'll start.
Look at that, they're there. Okay, I'm going to use them then. So is the first, but I can't advance them. Next slide, please. The first thing I want to note is we've been rightly pointing back one. Really? Okay. My favorite slide is out of here, which is we've been rightly pointing the finger at hospitals, at TPAs, at health plans. We haven't been pointing the finger enough at employers and purchasers. And I want to note that 32BJ is an exceptional organization. We've seen that with what they put on for us today. Totally, this is really. I need to repeat what Cora noted about the benefits. These are lower income workers who pay zero towards their premium, have no deductible, and low copays. That is not the reality for about 40% of American workers with healthcare coverage. About 30 to 40% of Americans with healthcare coverage have big deductibles. They are in broad network PPOs where they have a lot of choice with no quality, and they're losing in terms of what you heard from Zach in terms of their wages and losing jobs. And that is because employers in the last 20 years, what they've done is say, we're going to have broad networks, and our solution is high deductibles. High deductibles is not a solution to getting better quality care. Being willing to tier and encourage people to take better providers is a core part of the solution that is central to the 32BJ solution. So that's part of the context. I think it's so important to recognize you're in a setting which is not the normal purchaser setting. Okay. Part of being a purchaser is actually trying to buy right. I do have slides, and I'll fly through very quickly now. CalPERS is big. CalPERS represents all the state employees and other local employees in California, 1.5 million lives. Our self-funded PPO lives, though, which is about the size of 32BJ, about 250,000 current employees and about 150,000 MedSup. We went out to bid at the same time, and Claire and I were co-conspirators over the last couple of years, similar to 32BJ, said, here's our contract, not your contract, here's our contract, and we want you plans to bid. And we want plans to bid, but also vendors that could do good disease management, to really get into helping steer people to better providers. We went through a process of relooking at what we did. One of the things we had done previously, this is a chart of performance guarantees. Now, many of you I think might be purchasers, and if you have a self-funded block of business, you pay a monthly PMPM, per member per month fee. Often you have performance guarantees. I would challenge you to say most of your performance guarantees are garbage. They're, something at risk for data transfer, very little at risk for controlling cost of care, very little at risk for quality. This is CalPERS. They had about 3% of the fees at risk for quality and cost, and the rest for things that don't matter very much. That's not where we should be going. So CalPERS said we're going to do things differently. We're going to have a solicitation that looks at value, that looks at quality, that looks at cost, and managing the population's health. I'm flying through slides so we can get to the discussion, but you've got these to look at later. We ended up with a contract that is big and is different. That contract ended up with a new third-party administrator, Blue Shield of California, but also with included help to do population health management and help people get to better doctors and hospitals. Blue Shield provided a narrower network for a bunch of our members. That is hard to do for purchasers because members say they want everything. But as you heard this morning from the DOJ, if you have everybody in all the time, you are not creating a market. You are not pushing value and quality. CalPERS is ready to do that. It also, though, and this is what Claire mentioned, had really good steers, really good population management, but importantly, aligned incentives. What do I mean by aligned incentives? Instead of having 3% of their fees at risk, 75% of the fees that we're paying them are at risk. 50% are at risk for cost. And the cost target and this is, I'm going to echo what Claire said. In California, we have a healthcare Office of Affordability that set up a target that says by 2029, California's trend on all healthcare is going to be 3%. And there's going to be consequences if it's not there. That's a public policy initiative. We now have a contract that says starting in 2025, the cost trend for this contract will be 5.5%. It's going to go down each year. In 2029, it's going to be 3%. If our trends are higher than that, the third-party administrator, Blue Shield of California, and Included Health are going to write a check to CalPERS, a big check, not infinite, up to 75% of their fees. A biggest part for quality. The other part, though, is for, the biggest part for cost, the other part for quality. The part for quality is 6 measures. Right now, if you're a clinician, there's 8,000 measures. You're measured differently by each health plan. We've said in California, the 3 largest purchasers have come together. The Medicaid program, which is Medi-Cal in California, Covered California, which is the state marketplace that I used to run, and CalPERS. We're using the same measures. Between those 3 organizations, we serve over 40% of all of Californians. And we are using the same 6 measures. And if health plans work with all 3 of us, they're getting the same incentives to improve blood pressure control for people with hypertension, improve diabetes care. This is a focus we've not had in our nation's pay-for-performance rigmarole we've had that has not worked over the last 20 years. All this background is in sort of links to the material, but I'm actually going to close with one slide and not talk about the details of others here. Detailed charts. We spent a lot of time today rightly talking about affordability and cost. We haven't spent a lot talking about quality. And I want to note that we in America in the last 20 years ago, the IOM issued a report, Crossing the Quality Chasm. It said, we're failing in healthcare quality in America. In the last 20 years, we have not gotten better. We have not improved the care for diabetics. We have not improved the care for people with hypertension. National Quality Forum ran a study looking at our focus measures and said, if we improve the quality of care just for people with hypertension, with heart disease, which has disproportionate negative impacts on communities of color, if we improve that from where we are today to the 90th percentile, and 90th percentile is only 70% of people having blood pressure control, what would happen? 280,000 people would be alive in 10 years that wouldn't be alive otherwise. For CalPERS, 1,000 of our members will be alive if we raise the bar. So the thing that I want to leave you with is, as we're all talking about cost and affordability, we should always be talking about quality with cost. And we should be having as much on the line for helping systems make investments in quality improvement as we are holding into account for cost. So with that, thrilled to be here. Look forward to the continued discussion.
Claire, can I add something very quickly to what Peter just said about cost and quality? So sometimes people will suggest, like, okay, Sean, I'm a cost guy. I spend most of my time talking about cost, not enough about quality. It's true. People say, well, but you can't forget about quality. I know that's going to cost a little bit more. And I'm like, what makes you think it's going to cost more? And it's like, well, yeah, you have to pay for quality. I think everybody probably knows the answer to this question because it's a sophisticated audience. Does anybody think there is a positive, negative, or null correlation between cost and quality in America's hospitals? Anybody think there's a positive correlation? You pay more for better care? No. Anybody think you pay less for better care? Yes. Anybody think it doesn't matter? Yeah, basically it doesn't matter. Now, overall, in the aggregate, you actually probably pay less for higher quality because people are staying healthier. But if you actually just look at quality metrics versus costs at hospitals across the country, there's zero correlation, which is why when we think like, oh, we need to pay more for better quality, the answer is, excuse my language, bullshit. What we need to do is we need to find the hospitals that are in that upper left quadrant whenever we show a graph on this. There are plenty of hospitals that are lower than average cost and higher than average quality. We should be driving patients there. We can talk more about that.
Go ahead.
Can I add? I would like to add something to both their comments. Absolutely agree with what you're saying, Sean. And that has been my conversation with my partners, my healthcare carriers, and on my point solutions. Let's change the environment of negotiations. Instead of following a percentage of the charge masters, instead of following a percentage of Medicare allowable or reference price or FFS, whatever we want to use, let's talk about the quality. Let's reimburse based on quality. And that will really get us to where we need to get. And I have more to say, but I'll wait my
Actually,
turn.
I would like you to expand on it. That was going to be one of my questions, because you have chosen, one of the strategies you did was to exclude low-value provider groups, which, as I understand, was the intersection of price and quality, such an important measure. And Peter is instead essentially rewarding in some ways. But so do expand on that, because I think it's a super important. You're each taking in similar concepts but manifesting it differently, and part of our goal here today was to let you understand there is no one magic formula.
Correct, and thank you for that. So before expanding on that, if I can provide some additional information about my great district. Like I said, we're the third largest district in the nation. We educate 350,000 students. We have 500 locations. We have 397 schools. We have 32,000 full-time employees, 6,700 part-time, and 9,241 retirees. My healthcare expenditure, like I mentioned, is projected to go up to $441 million next year, and it's obviously my second largest expenditure, like with many employers, right? We're 53% chronic, and out of that 53% chronic, 44% are cardiodiabetes, a new term. Right? Talk about an interesting industry. We're always coming up with terms. So cardiodiabetes is the combination of having the three conditions: cardiac problem, obesity, and diabetes. So 44% of my 53% chronic, which is driving 89% of my expenditure, are cardiodiabetes. So definitely need a solution, need benefits that are aligned with my employees' need benefits that are aligned with the industry that is always constantly changing, and benefits that are sustainable. So we all have a financial, right, a fiduciary, as the term is known, a fiduciary responsibility. And for me, that's extremely important, because I use taxpayers' dollars to pay for our healthcare plan. And I take money out of people's salary, as being mentioned before, because in Miami-Dade County Public Schools, salary and benefit does share the same pot of dollars. So for next year, part of my strategy, well, all my strategies combined, is saving the district $11 million. And one of the strategies is removing providers that are not willing to come to the table and have a conversation about quality and about cost. I remove one of the health system from one of the plans specifically, another very large health system in Broward County from all the plans, and 2 years ago, or a year and a half now, maybe, I removed a huge 800 doctors, OBGYN and GYN, and we're 67% female. So imagine the number of referrals, the number of nasty emails, because people got upset, right? And I stood in front of my C-suite, and I report to the CFO. That's something else. I recommend anyone who's in charge of benefits, HR does not understand this language. You speak with an HR director, and they cannot throw data. They don't know their data unless you're in finance. And I went to my C-suite, I went to my CFO, my boss, and I stood in front of their union leaders, because I also negotiate with 5 unions in Miami-Dade County Public Schools. And I said, do you want me to pay the 60% increase without the backup indicating why, justifying the increase, or do we terminate? Because I am terminating. Flatline, there was no comment. Because nobody wants to, say, yeah, get rid, because then I'll say so-and-so told me to get rid. Right? Everything is a strategy. So I said, okay, I'm interpreting that as a termination, and proceeded with the termination. And 6 months after, almost 7 months, they came back to the table with a 10% increase. So the opportunity is there. And today we've had such an amazing conversation, even though I've been upset almost the whole day, because I'm like, we need to do more. But the reality is, yes, policy is very important. Education is very important. But employers are the ones paying this bill. Employers need to take a stand and understand what they're paying for. And the federal government, and my apologies to anyone here, politician, the federal government needs to do a better job in holding the healthcare systems and the healthcare carrier accountable for sharing the data. The CAA only came after us. So either I attest with just an email saying you're good to go, because God knows I'm old and fat, I don't look good in orange, right? That's what I told my boss. Or I don't attest, and then I can go into jail and get fined. So I attested. And I have all this documented in an email because I was very frustrated. Why doesn't the federal government hold to the same standards, insurance carriers, brokers, consultants? A comment was made earlier today which I have to respectfully disagree. I will not say it's the insurance carrier's fault. I will not say it's my consultant's fault. We have allowed this. They're doing what they've been trained to do for years and years and years. Employers need to take a stand. I cannot say it enough. It's time consuming, you're ruffling feathers, politically it may be very disruptive, but you have a fiduciary responsibility that's going to impact all of us when we get to Medicare. So yes, because of quality, I removed one of the health systems from the network. And they're not coming back because their quality, even if they agree to the fee, they're not coming back because their quality is horrible. So yes, understand your data, know what to ask for, and be engaged. And that's what I ask you to please do as a large public employer.
Bravo. So I've been doing this for decades, and we talk about quality, and it's a little baffling. There's a lot of different measures. We heard from a physician earlier today, and we hear this all the time in our offices, that it's really hard for physician practice to have to monitor and measure so many different measures, and every health plan says they have the best program, and it's a little bit of a mystery as to whether they'll get any of their quality withhold back later. So one of the things I would like to challenge the group on, and let Peter start, and then you all respond, is this concept that when you pick a few, and yes, it means that maybe the pet issue that you think really matters may not make it to the top list, but it means that everybody's rowing in the same direction and looking at the same measures. It introduces a level of efficiency and understanding and common motivation to really think about whether there's a way for all of us as purchasers in our own communities to say, can we agree on common measures with our large public purchasers? We talk about collective purchasing. It doesn't have to just be about negotiating prices. There's a lot of ways we can use our leverage together. So Peter, talk to us a little bit about what it took to get your board to this decision, and what kind of resistance you had from maybe your brokers and consultants, or sort of this. You bucked the status quo, so that's what I want to hear about.
Well, I'm going to note a mixed answer about the complexity of this issue. This started when I was at Covered California, but it also goes back to when I was in the Obama administration working at CMS, saying, what are the measures that right now we reward Medicare Advantage plans $11 billion a year for quality measures, and they are gaming this by coding, not by improving quality. So we've got this is a problem that ripples through the system in a lot of places. We looked at which are the measures that actually are most valid and relate to outcomes. We did sort of what you hear 32BJ does all the time. Data nerds looking at the information and sharing and saying, we've analyzed 63 measures, here's the 12 that are most valid, had clinicians and others at the table kicking the tires over that said, yeah, these 6 matter the most. Now, Medi-Cal, California, has 9. They've got more on kids because they got more kids there. But they're aligned across. We're also, though, aligning not just with purchasers, but with our state regulator. The Department of Managed Healthcare says, here's 15 measures. However, one of the things that I want to note, we spend as much time as a purchaser looking out for the unintended consequences, because this may be the right way to pay a plan. I'm not sure it's the right way to pay a doctor. Because if you have a boatload of money going to a measure, there's the problem they'll classically teach to the test. And this is where we want payments that promote coordination and integration. We are looking at Blue Shield to pay not based on these 6 measures, but rather to pay better to primary care in general, to pay better to coordinated care through ACOs. So I think we need to look at the measurements and how we reward a health plan that then has an incentive to support quality improvement, to support a practice doing a better job. So this is, healthcare is complicated. We think it's the right thing to focus on a small handful of measures, but be very careful about where you then say that ripples to. Because if you say to a doctor's office that a big bunch of your money is going to be tied to this measure, all of a sudden, everyone's a hypertensive and they're really healthy ones. I mean, there's all sorts of things that you can do to teach the test. So we need to look at both of those, and I would say as a purchaser, if you're putting standards in place, spend as much time following up on what may happen into the negative as well as the positive. So I'll give you one last example of that, and this is our worry when we said these are the new standards that have health plans with 42% of covered lives with similar measures. Well, the easiest thing a health plan can do is I'm going to get rid of that medical group that looks like they've got a worse score in these 3 areas. Well, if that medical group is in East LA and is the main group serving Latinos, and maybe has a worse score because it's not risk adjusted and adjusted for the population they're serving, I don't want to lose that group. So how are we then holding ourselves to account as a purchaser to make sure if we set incentives in motion, they end up doing the right thing?
Yeah, I don't have a good, Peter has had a great answer. I don't have a fantastic answer for this question. Just to say, I won't say who because it hasn't been officially announced yet, but I was asked to join the board of a national quality organization. And I said, are you sure you want me? I don't know how to do quality measurement. I never designed a quality measure. And they're like, no, we really want to understand what employers and purchasers want. I was like, all right, well, we'll see how this goes. I said, I've also pissed off a lot of hospitals out there, and they're like, yeah, that's good, that's fine. Just a couple of thoughts. I think, one, we already heard from a clinician earlier about this measures overload, and I can only imagine how difficult that is. I also feel like in the employer space, particularly as we kind of talk about our focus on costs and our focus on quality, sometimes we're at an interesting tension. We have been trying to move toward, accountable care, toward, better measurement of quality, and so much of that requires the kind of mass necessary to take in that data and actually use it, which is a driver toward consolidation. And simultaneously, we have been pushing very hard against consolidation in the healthcare system. I haven't figured out, I don't know if others have, I haven't figured out exactly how to deal with that problem because we can't sacrifice on quality. But on the other hand, I don't want to be taking smaller independent physician practices and sort of giving them yet another nudge to go into to be part of a hospital system or a large insurer health system. To me, as I think about where our measures need to be focused, it's got to, for us, it's got to be a measure that is correlated with lower costs as well, right? I want to see measures that are improving the outcomes for patients. They're not process measures, they're actually outcomes, but those improved outcomes actually equal, us spending less money in the long run because we can't lose sight of the cost conundrum.
Does anybody want to add, or shall we move on?
Sure, I'll add.
Sure.
We use, the Florida Alliance for Healthcare Value is the regional leader representative of Leapfrog. And when I'm sitting across the table with a hospital, I bring in the Leapfrog report. And we were just part of the high cost claim with the National Alliance, and I was one of those employers that was lucky enough to get my data. When I looked at my data, I was shocked at the high level of sepsis cases that I had. And when I asked my carrier, do you look at this data? Did you see if there was a direct correlation between the infection and the condition? Are these cancer patients, HIV patients? Are they specifically at one location? Is it outpatient versus inpatient? And they looked at me like I had 3 heads. So the thing is that you really need to, I don't know about the smaller groups, but you need to take a look at your data. We're back to the data conversation. But define what is quality, because quality can mean different things, right? Quality for my district, when I ask my employees, is making sure I get an appointment. That's not quality. They don't even understand what quality is, right? So quality definitely, in the forefront of the conversation, but understanding what quality means to you and that you can measure it is extremely important.
Well, I think the difference between the member experience versus quality is
They think that's quality.
Is absolutely critical. Well, and that's how people experience the healthcare system. So, Sean, you have taken a very high profile with your members in trying to get them to actively engage in policy at the state and federal level. Peter, you have a rich track record at almost every level. What do you find to be the most effective or maybe the most frustrating aspect of getting purchasers to recognize that their world is impacted by policy as much as by their market activities?
Sure, it's a great question. So as Claire said, I come out of hospital world. I represented the Children's Hospital Association for 4 years as a lobbyist. Do great work, charge enormous prices, we're all very familiar, and the public hospitals for an extended period. Do good work, charge pretty high prices, but also are treating a very significant disproportionate number of low-income people. Hospital CEOs, hospital government relations people, hospital CFOs, you name it, they're very engaged in policy. Why? Because frankly, most of their money is made from a public purchaser. So we spent a lot of time on Capitol Hill, and they were very interested in coming with me when I was going to go up and meet with members of Congress and their staff. I come into employer purchaser world, and they're like, I don't know, it's scary. I mean, our brand, I'm going to have to talk to legal, I'm going to have to talk to marketing, I'm going to have to talk to whomever, and somebody's going to say no. The case that I've tried to make, and we're making progress, is baby steps, one step at a time, and the recognition that I am, at some level, a political hack, right? I've never been a purchaser. I mean, I just signed off on the contract for the group at the National Alliance. There's 8 of us. We've got 15 people in our plan, a third of whom are my family. Like, that's my experience with purchasing, guys. That's it. The voices that actually matter are the people who are actually doing this work. And I'll give you sort of a very quick example. So last spring, we were up on Capitol Hill. We do a couple of big meetings every year, and we try to do a Hill Day. We bring up the employers and purchasers. Rosa's always come. And Cora was in the room with me. We were talking about a particular issue at the time. It was around PBMs. And this sort of stupid issue was raised by the PBM industry. I won't get into it. It was bullshit. That's the second time I've said that today. And the staffers were like really worried about it. And I sort of stepped in. I'm like, I'm a lobbyist, or was a lobbyist. I'm trying to sort of explain why this is a dumb idea. And Cora, in her very kind but also very direct way, was like, let me explain how this happens in the real world. We need that. We need somebody who can say, let me explain how this happens in the real world. And one of the things the case that I would make is for employers and purchasers, and why you have to get invested in policy, is I can't do it by myself. People like me can't do it by ourselves. We need your voices. And you don't have to be 32BJ. You don't have to run a big campaign calling out a hospital system. You don't even have to put your company's name on something, right? That's why you have advocates like me, where I can put the National Alliance name on a lot of things that are a little bit more controversial. What I need you to do is to provide us with the insights, with the direction, with the data that we can use, and to the extent that you can, come to Capitol Hill, join a phone call, have a conversation with policymakers. You're not putting your name out there. You're literally just saying, hey, I am this person. Here's what I'm experiencing on the ground in my area. Here's how this hospital system or this TPA or this PBM is screwing me over. Please don't use my name in your press release.
And I will say, coming now from the union perspective, we know how powerful it is when union members show up and make their voices heard. It is equally powerful when employer purchasers show up and make their voices heard. In the experience I've had over the years, our most powerful changes that have happened in different state and different federal levels have been when we've had employers who aren't sophisticated, who aren't smooth, but they know what their story is and they know how it works. So it is really very, very powerful. So Peter, I think you had something to add, because we were talking about that.
The main thing I'm at is the frustration and the challenge with this. I want to echo something that Sean said, is that if you're in the halls of Congress, if you're in the state house here, the hospitals have full-time, dedicated lobbyists spending boatloads of money around what is their business. So do the health plans, so do the PPMs. If you're an employer, your number one issue isn't healthcare. That's your number 4 issue and a subset of your employment costs. And so the challenge you have is getting employers that will say, it's important enough that I'll show up and testify. It's important enough I'll go to a meeting. It's important enough I'll put a name on it. And that is not what most employers are going to do. I mean, that's just the sad reality, because Most employers might be a bank. 20% of their clients are healthcare clients. I mean, so it's part of the real politics of this, but it also says if you are an employer, a purchaser, one of the reasons I think we see more Taft-Hartley Trust and the groups like 32BJ, groups like Unite Here, groups like the Carpenters, some unions and public purchasers, is they're a little insulated. They're able to talk truth on what's really happening and see what it means to the wages of the people they're working with. That's really important. And to find that small handful, and it will always be a small handful, of private employers that will step up and make their voice heard. A few years ago, 3 of the biggest employers came together to create Haven. It was Amazon, it was Berkshire Hathaway, and it was JP Morgan. After 3 years, they folded their joint effort because they couldn't work on it together. It's really hard because each of those 3 entities had their own conflicted issues. Amazon now owns One Medical, Berkshire, et cetera. So it's a challenge, but what we have to do throughout is to say, you won't get the Chamber of Commerce generally signing on to these things, but you will get 3 employers that are known and recognized that'll go to those meetings on the Hill. And that's what we need to be doing.
I'm going to switch gears a little bit. So we've talked about, so you talked about being willing to eliminate a system. We've heard several times today about the travails we've experienced in trying to eliminate New York Presbyterian. Peter, I know you have said it's really up to your carriers to do a lot of the contracting, but how are you dealing with the kind of anti-competitive contracting clauses, or have you encountered them, Rosa and or Peter, in your state, so that you've said, actually, you are not a high-quality system, and you are very expensive, and we've explained it to our members, and so we're willing to do that very difficult, the large OB practice. How are you all dealing with those issues, and how do we make those issues become more relevant to change?
Sure, I'll start. I'm dealing with them head on. I am letting the C-suite, I'm letting my union leaders, I'm letting my employees know. We sent out an email letting everybody know this health system is increasing by X percentage with no backup, no justification to why the increase, and we're proceeding with termination.
I guess the question is, how are you being permitted to terminate? Not by your bosses, not by the C-suite, but by the administrative carrier.
Sure. So the administrative carrier, they've been our carrier since we went self-insured, and that was on September 9 of 2009, so it's 14 years. We just had a birthday. And every time they're at the table in negotiations with a health system, I've already gone to the health system and I've had a conversation about the financial challenge that my district, my employees are facing. And when the carrier cannot get the rate that we need, I let the hospital know, I am terminating you, because I'm telling my carrier, do not enroll. And we're really creating a lot of awareness and engagement and conversations at Miami-Dade, because other employers who also have my healthcare carrier as their carrier, their ASO carrier, not a TPA, I have an ASO, they will call me and say, you didn't accept that contract, you terminated? I said, yes, I did. Because now the health system is calling all the other employers. So that's one of the ways I do it. The other way is through direct contracting. And the challenge with that is that my data today, because I am releasing an RFP next year, and all cards are on the table, it's gonna be a different conversation, and I may not even end up with an insurance carrier. I don't care. I will move into direct contracting. But the other method is direct contracting, but the carrier doesn't accept the data. There's not one of the BUCAs who I've spoken to that will accept data on direct contracting to make sure you have captured disease management, utilization management, gap in care, all those wonderful data points. So what I do is that I have that carrier who I've contracted with share the data with my consultant, and they maintain a data warehouse for me. And that's how I use my data, right? So those are the 2 ways up to now. For next year, I am removing another strategy is that I'm removing advanced imaging from one of the educational health systems in my district, who is charging 500 and 600% above Medicare. And that alone is almost a $2.3 million savings. For the following year, the low-hanging fruit is that advanced imaging will not be, unless you're admitted, will not be offered at a hospital or hospital-affiliated facility. And those are conversations that I'm actively in now. Obviously, I have to have the network, right, to make sure that I can move in that direction. But again, employers need to take a stand and make some difficult decisions. It's not all about policy, because policy does take time.
So you took a very different approach than direct contracting, which I think is fascinating.
Well, it's direct contracting. If you're serving 1.5 million people across an entire state, is hard. Who do you choose to direct contract with? But the challenge that we have is often systems will have, you must contract with the entire system or you lose everyone. And if you're a system like Sutter, which is a big system in the Sacramento area, it's got 39 hospitals, et cetera. Back to that distribution of cost and quality, they all are as good, all is good. Similarly, there might be a imaging center, which is really high cost. Their contracts have historically said it's an all or nothing, and that is their contract they have with every one of their health plans, which disables you as a purchaser to tell that plan, well, plan says, I'd love to, but I have to keep all of them. This is where policy comes in. This is where in California there's a state law to prohibit the systems from doing that. Now, a note about 4 years ago, through purchasers with the state AG sued Sutter, that system. And it's one of the national leads of saying these practices should not be allowed. CalPERS got some tens of millions of dollars as part of a settlement that a lot of other purchasers got. But there's still the practices out there, even with Sutter. And so this is a matter of where purchasing isn't enough without policy saying you can't have contract terms that require you to have all in. So this is a still in play issue where the marriage of purchasing and policy have to come together. Because without outlawing it as a matter of law, that health plan is still going to negotiate whatever they think is the best term, but if they want that large system in, they will accept those terms.
And Rosa, that's what I was trying to get at, because we've certainly encountered that. So our members are willing to do it, et cetera, but it is all or nothing. Do you not have that in Florida?
I do, but we also have a very open relationship with our healthcare carrier, and they are that partner, and they understand our challenges. And yes, there are those instances in which it's all or nothing. So I go through direct contracting, and I use my data, the database that our consultants maintain. It's very difficult. I don't know enough about that side of the house, right? I have a couple of books I've purchased, and I need to learn what really precludes them from that opportunity. 3, almost 4 years ago, the head of Mount Sinai, a huge health system in Miami Beach, came out publicly saying, we're going to share data. Everything's going to be transparent. I guess he didn't, get the memo, because a week later, he came out saying, no, it was a mistake. So it was interesting. But yeah, there's different ways of doing it, but a lot of pushback, absolutely.
Go ahead, Sean, and then we're going to switch from there to opening up to questions from the audience. So if you have questions, maybe start to raise your hand so that our roving mics can find you.
So as we take questions, I was just going to add, I think to Peter's point and Rosa's point, so much of it comes down to the contracts that employers sign at the front end with their TPAs or the ASOs, right? And which is why I just love the contract first model that 32BJ has pioneered and that they've now made available to everybody. It's certainly, we plan on making that widely disseminated through our network. It's critical. If you sign terrible contracts at the front end that lock you in and that keep you from getting access to data and allow them to engage in contracting with providers that are anti-competitive, you're kind of screwed for a while, right? Until you get to renegotiate that contract. You don't have to write that contract. You don't have to sign that contract. Obviously, if you're 32BJ, CalPERS, Miami-Dade Public Schools, you're big, you have more leverage. But I'll be honest, we have a lot of sort of mid-market and smaller employers. And I'm often hear from smaller employers saying like, well, I'm not as big as United Airlines, I can't do this. One of our most sophisticated, aggressive, thoughtful employers in our network is a small company in Alabama. Actually, if you go to, if you know Noam Levy at Kaiser Family Foundation, there's just an NPR piece on Pfeiffer. This is a 3,000 person company in Tuscaloosa, and they have one of the most employer-friendly contracts you'll see. They have their own on-site clinic. They don't allow any sort of anti-competitive stuff, and they're in a state that is dominated by Blue Cross Blue Shield of Alabama that has over 90% of covered lives. You can do it as a small employer if you're aggressive enough. So don't take up this idea that you have to be the size of 32BJ to be as effective.
We did it in Colorado too. So do I have questions?
Thank you, and thank you for this presentation. Alan Klinger from the Steptoe Law Firm. We represent public sector unions in New York City, the UFT, the teachers union being one. Question for Rosa is, I understand, and I know Florida labor law is different than New York, but did you get pushback from the unions about what seems to be an aggressive stance with removing hospital systems from network in terms of that being acceptable to the union membership?
Sure. Thank you for the question. I did. But again, because salary and benefits truly shares the same pot of dollars, they understand that aggressive measurements need to be taken in order to continue to offer a plan that is affordable, that is sustainable, and that meets our employees' needs while still paying salaries, not that they deserve, because they deserve much more than that, but giving some increases every year. So we negotiate with the 5 unions that we have, and there were difficult conversations. Right now, we are in active negotiation, and very difficult conversation. The conversation of removing advanced imaging from the hospital. When I said it, they looked up and said, "You want to do what?" I said, "No, I am proffering to do this because of this savings. And I have the network to support that if I remove this, there's network adequacy." And then they understood. Because they're also trying to fight to get salaries. And we're not properly funded. So they understand that. But yes, pushback, but we do have a very good partnership with my unions. Huh?
Did you have any union interaction, Peter? I know this was mostly for the non-union segment of CalPERS.
No, it's a lot of union people. The board of CalPERS has union representation on that board. And it's one of the things that is one of the tensions in our contracting. The PPO model has virtually, and this is where we didn't have quite of the backbone as 32BJ, both of the networks for what's called Platinum and Gold PPO have virtually all the hospitals still in. We didn't make the hard call of saying, pull out Stanford, not because I'm there, but they are expensive, or other big systems, but rather we pulled out for one block about 25% of the docs who channel to the more expensive hospitals. So it's a matter of where you make the play of who you're going to exclude. And it is, though, a matter of having steerage in a way that actually can help consumers get to that better provider. The endpoint, hospitals are huge drivers. Cutting some out, some of the service out, I think is a vital piece. But it is politically, and it's also hard if you're an employer, because employers hate friction too, which is why they took the quote-unquote, I hate to say, easy path of broad networks and crappy high deductibles, rather than the harder path of saying, we're going to keep the cost lower by excluding. So,
Elizabeth, I know you had your hand up. Okay, sorry. And then Spencer, who was next? You can. Okay. Oh, do you want?
Hi, Elizabeth Benjamin from the Community Service Society of New York. And this is a question somewhat for Peter, because I don't think it so much applies to BJ, which is very admirable in that it doesn't have cost sharing for many of its benefits. But I'm kind of interested also in insurance plan design. So for example, New York is the first state in the country to get rid of all cost sharing for, and I think Senator Rivera, I'm not sure if his staff is still here, and for all insulin, and maybe having $0. There's that great study from Blue Cross Blue Shield of Louisiana that did $0 copays for heart disease, all the medications you would need for sort of your basic chronic conditions. And then you mentioned primary care, and I sort of wonder if we should be thinking about $0 cost sharing for seeing primary care doctors as another way. Is there other data, especially in your journey from the California Exchange to CalPERS, is there some joy to be had there, if you will, in terms of, yeah.
Well, I love the question, because again, I can't celebrate 32BJ enough, and to note that the experience reality of 32BJ members is not the average journey of most employed Americans. Big deductibles, for 30% of Americans with large deductibles, that deductible is between them and seeing a primary care doctor at all. So they might need to have a $3,000 spend before they see that primary care doctor. A couple notes of reference. In California, after I left Covered California, which is the state marketplace, they took some state money and added it to the expanded subsidies. So in the marketplace today, everyone gets coverage with zero deductible. And I think deductibles are one of the biggest problems, because if you've got to spend some thousands of dollars, and this is something that state policies can look at, and we should be looking at federally, to say, do you really need a deductible between you and your primary care doctor? My answer to that is absolutely not. The next question is copay. And I think it's a harder one to say, maybe you have a $10 copay, maybe a $20, but you have a deductible should never be happening. And this is a kind of issue for standards we need as policymakers of where do we have, for lower income people, benefit designs that make access impossible. You won't see that, I'm sure, in Miami-Dade, because this is where...
I do.
Oh, damn. Sorry.
What's wrong with the two of you? Let's do it briefly so we can have one more question.
Sure.
But absolutely
Yes.
address it.
So real quickly, thank you for the question. I do offer zero copay to primary care doctor. I offer 70% of the medication for chronic management free of charge. And I have a free plan that is not an HMO, doesn't require referral. And the maximum, the whole year, and every dollar goes towards that maximum out of pocket, is $1,500. Yeah. So it's a very rich benefit. So we do, public.
Well, but I just want to know is these examples are, in richness of benefit, very rich benefit designs, which are great, which is not what 40% of American workers do not have rich benefit design. So then how do you have benefit designs where it's not rich, that has low hurdles to get people into primary care that will help on the back end? So it's a challenge.
Sean, and then we're going to open it up to, I know we have another question.
One right in front.
Thank you. But hold on, we're going to let Sean have his...
I can do this in 30 seconds or less. Deductibles are dumb. We should get rid of them. They're just dumb. Copays, I think there is actually a role for copays in a one mechanism of driving patients into particular places, right? So one option would be to say, I'm taking this person out of network, they're overpriced or they're low quality. Totally, do that, please. But another way you can do it is if you say, well, look, we want to keep a broad network. Some patients really like to go to overpriced oncologists that aren't very good. If you want to keep that person in your network, have a variable copay. And you say, look, if you want to use this person who we've identified as being low cost, high quality, it's a $0 copay or a $10 copay or whatever. If you want to go to see that guy who's, cousin Ned's best friend, it's going to be $1,000. And again, we can debate whether there's sort of a moral choice there, but if the goal is to actually drive patients and steer patients in the right direction, copays are at least a mechanism to be able to do that, so long as there are options available that people could actually afford. Unlike a deductible, which again is just, a barrier to care.
Okay. Quick question.
I just wanted to point out that the Congressional Budget Office in 2023 came out with a report that value-based payment over the last 10 years raised costs and is expected to raise costs the next 10 years. Value-based payment doesn't work. I think you should definitely negotiate for better prices, but value-based payment doesn't work. There's not a doctor I know that doesn't want to prove the control of hypertension and diabetes. But we know from electronic records that 50% of patients don't even pick up the full course of their medication. Value-based payment also creates a conflict of interest between the doctor and the patient. There is a ton of evidence of sicker patients being pushed out, socially disadvantaged patients being pushed out. And yes, these models have tried to correct and adjust for them. I don't believe they're doing it. It's very easy to push out a patient with dementia. They've been shown to be pushed out. I was trying to help a friend make an appointment. You call the office and it says, go to www. to make an appointment. No patient with dementia or a little bit of dementia can do that.
Thank you. That's a great observation. Do we have any other questions? If not, we are okay. I'm sorry, I'm not tracking with this. Okay.
It's Al.
Hi, my name is Al Charbonneau. I'm the Executive Director of the Rhode Island Business Group on Health. In another life, I ran hospitals in upstate New York for 35 years. You might say I've drunk the Kool-Aid. My question is, and I was late getting to the meeting, so my question is, have you considered looking at the value proposition for hospitals and beginning to say it's not just high quality at the lowest possible cost, but it's also efficiently produced? And have you considered looking at any performance metrics for hospitals in this region? I can tell you in Rhode Island, our overhead costs are going up to almost 52% of total expenses, and we are like the third highest in the country, by the way, only outpaced by New York City.
I'll just very quickly answer that, Al, from my perspective. From my perspective, at some level, I don't actually care whether it's efficiently produced. I care whether the cost is low, but I totally understand that part of the reason that hospital prices are so high, part of it is lack of market competition, and part of it is that they're super inefficient, right? We know certain hospitals are incredibly inefficient. At our annual forum, which I encourage everybody to go to if you want to spend more of time talking about this, in DC, November 18th through 20th, nationalalliancehealth.org. We're going to be hearing from Peter Pronovost at University Hospitals in Cleveland, they've made a commitment to say they're going to bring their cost structure down so that they can break even on Medicare. Hospitals can do this. Some hospitals break even. Some hospitals make money on Medicare, despite the industry saying, "Oh my, we couldn't possibly. They're so underpaid. We have to charge you 250 to 500% of Medicare prices." So I think it is critical that hospitals become more efficient, which will allow them to be able to get to lower prices, and then it's on us to be doing better negotiation.
Thank you, Sean. You got the last word. So thank you so much to our panel for a lively debate.
All right, don't go anywhere. We are almost done. But right now it is my pleasure to introduce Howard Rothschild, who's the president of the Real Estate Advisory Board. He represents the critical voice of the employers in the work that we do here. It is his courage and leadership, and that of the employers he represents, is one of the reasons that we are here today. He also tells really good jokes. And so I'd like to invite him up to say a few closing words.
Well, thank you. I was trying to think of a way to keep everyone in their seats, given, you have busy schedules, and I came up with two ideas. One, the slide that Zach Cooper showed earlier today about the Toyota Corolla. So the first idea was to give a free Toyota Corolla to someone in the audience, but our budget is limited today. So the second thing is, I know you have busy schedules. I've been allotted 15 minutes. I make deals with the union, and I'd like to make the deal with you, which is I promise I'll be much shorter than 15 minutes, but only if you promise to pay attention. So do we have a deal? Okay. So I wanted to break this presentation into two parts. First was a very quick review of other presentations today, and about 8 or 9 takeaways that things that just astounded me. One, the presentation by Ryan, consolidation of hospitals has led to anti-competitive hospital prices. Two is that the government is sharing resources. There's now a task force of the DOJ, FTC, and Department of Health. Normally these agencies don't want to even talk to each other. They have their own turf. To me, that's a sign that the government is looking at this and taking it very seriously. And what they're focusing on is combating anti-competitive hospital prices. The presentation by Zach Cooper I had thought of some of the things in the line. I hadn't thought of all of the downstream problems. So he went through the process of increasing hospital prices, reduces jobs, that I got, reduces wages, that I got, reduces tax revenue, I never thought about that, increases government spending, and I never thought about that. And lastly, it increases mortality. That really, really got to me. I don't know if it got to you. The presentation by the mayor of Newark, that the city has 8,000 workers. They left the state health plan and saved $10 million. Think about it. That increases the cost per employee by $1,250. That's just phenomenal. The presentation by Senator Krueger about the Fair Pricing Act, that'll lead to transparency, accountability, and enforcements. And in her view, hospitals now control all of healthcare. And that's really through the consolidation. The panel discussion about site-neutral legislation, 4 systems have $24 billion of assets. That's measured 4 years ago. NYP alone has $11 billion. If we enacted the legislation, we would save $1 billion. That's 2022 prices, and that's on 57 types of services. This is very late in the game, but it should be done tomorrow. Read from the White House, nationally, our country spends twice the amount for health care, and the results are worse than our peers. Always consider quality and costs. It will save lives. And understand your data. If you know your numbers, you need to be engaged. And then the final thing was, we all have the opportunity to do good. So those are some of the things I learned today. So this day began with Manny Pastreich, who said, why is a labor person kicking off this conference? And I guess my question to you is, why is a real estate management stooge closing it out? I'm not quite sure, but Cora can be very persuasive. So I work for the REB. It's a multi-employer association. We represent employers that provide services in residential and commercial buildings in New York. Our members operate a wide variety of buildings, employ about 85,000 workers in a highly unionized environment. And under our collective bargaining agreements with 32BJ and other unions, we provide generous benefits, including exceptional health insurance. I've worked at the RAB for 40 years. For the first 20, health insurance moved at a relatively slow, predictable pace, matching inflation. For the second 20 years, the increase was more than twice the rate of inflation. Our employers contribute to many union health funds, and today the cost of health insurance is more than 3 times the combined cost of defined benefit pensions, 401k, training, scholarship, and legal benefits. More than 3 times the combined cost of all of that. So it's enormous. In New York today, about 40% of our health expenses go to just 5 hospitals. And the money we designate for health care is money that's not available to us as employers and is not available to our employees for things like wages and other benefits. So these cost increases can be viewed through various lenses: as a consumer of health services, as a trustee of the union funds, as a negotiator of collective bargaining agreements, and clearly, healthcare costs, and specifically hospital costs, need reform. Make no mistake about it. I believe that hospitals should charge a reasonable fee for their services. They serve the vital interests of the community, but I don't believe that they should be padding their reserves with our hard-earned money. You've heard from union officials, elected officials, the DOJ, the White House, healthcare experts, hospital administrators, and today I'd like to give you the perspective of our employers in collective bargaining and as an employer trustee, looking out for the interest of our employees participating in the various Taft-Hartley funds. And I'm only going to cover 2 points. First, what have we done to reduce the rate of healthcare costs healthcare costs that increase in our jointly administered funds? And second, what does the future look like? Our fund has been diligent in attempting to contain and control costs. We have limited our network, created centers of excellence, rebid all of our service contracts, and analyzed the data. The good news, in the last round of collective bargaining, we pegged employer contribution increases to 10.5% over the next 4 years. The bad news, we, like other employers, are trending at an 8% cost increase for the first half of this year. That puts pressure on our great fund staff and on the trustees to try to devise ways to save money. For example, in a recent RFP for our ASO provider, we're a self-insured plan, we negotiated the terms of our service contract before selecting the vendor. This will save our fund tens of millions of dollars each year. We required bidders to use our contract template, which I presume is now on the website. I heard about that. Great. It took us a long time to do that, cost us a lot of money. You can get it for free, so avail yourself. We included terms requiring full data ownership, transparency, disclosing and retaining medical rebates, permitting direct contracting, demanding upside-down claims adjustment, medical record review for high-cost claims, and greater audit independence. Putting the contract first and not later in the process allowed us to express our fund's priorities in a way that could not easily be papered over or discarded in contract drafting. Some people think this is putting the cart before the horse, and in a way it is, but it's necessary these days. This stuff is very complicated, and getting your point across to your provider is very important. In attempting to control healthcare costs faced by our funds, we also created and funded the Labor Industry Cooperation Fund. That fund provides a vehicle to further the interest in providing low-cost, high-quality healthcare and unites the interest of employers and the union. At the LICF, both parties are determined to use our position to work with our hospital providers to further bend the curve of increasing healthcare costs in a way that is fair to patients, payers, and providers. With $6 million dedicated to this work already, I can say that management and the union are deeply invested in tackling this issue for the long term, and we are in it to win it. We owe it to our participants. Nothing else is acceptable. Every dollar spent on healthcare is a dollar not available for other benefits, paid time off, and most importantly, wages. As a prudent trustee or anyone with decision-making authority, time invested wisely up front can pay dividends long term. This has ultimately led to some success, but we continue to be diligent and vigilant. So, second question, and you'll be out of here. So what does the future look like? We will not rest on our laurels. Nationally and New York, healthcare costs continues to show no signs of abating, and our hospitals often drive these increases. Until these cost concerns are brought under control, our ability to provide coverage without sacrificing wage growth is at risk. This is true for all employers. So if the status quo does not change, I'm not optimistic. However, this conference gives me hope. The fact that this is the third year we have held this conference, and each year the attendance doubles, is a clear sign that others are interested in this issue. However, no single employer or fund can do this alone. For example, I am a trustee on another local union fund that is involved in a national coalition for prescription drugs. When it comes to fighting big pharma or the hospital industrial complex, I would urge anyone who is interested to contact our fund and see if there are common interests where we can work together. I've spoken today with representatives from other like-minded organizations. It would be even better if we could unite in a common cause against unsustainable hospital and healthcare cost increases and engage with our providers in a meaningful discussion on how to affect change. But for now, we need to band together as payers of healthcare. If we do not care about our employees' health or our own wallet, who will? I urge you to act in the interest of your employees and your own interest. I hope you've enjoyed the conference.
Thank you so much, Howard, for your ongoing support. And thank you all for attending. Before you leave, I just want to say two things. One, thank you to everyone who attended, and thank you to the Health Fund staff for your diligent work. I want to give them all a round of applause. It truly does take a village to pull something like this off. Have a wonderful day, enjoy the sun, and don't forget your coats on 4th floor. Thank you.